Is the mic working? Yes. So good morning, everyone. Welcome again to the second day of our retreat. It's a pleasure to have you all again around the table. This year, the meeting, we have replicated basically what we did last year as a second half a day post our retreat. So this is again another meeting, very focused meeting, sponsored by the IBCG, the International Bladder Cancer Group, and the Global Society of Rare Geo Tumors. This year's meeting will be focused entirely on the developments on liquid biopsies in geocancer. We will have, for the reason that you will easily understand short after, a special focus on bladder cancer and urothelial cancer. We have again, as last year, a multi-stakeholder table involving academic guys from multiple specialties, urologists, oncologists, radiation oncologists, friends, most importantly. We have pharma company guys, industry people, and regulatory authority people that I see connected already on Zoom. We have a strong connection by friends online. So the meeting is also broadcasted via YouTube. So welcome to everyone who is following us today via YouTube. So I leave the word to my good friends for a short introduction, and then we will start. So I leave the word first to Ashish Kamat to introduce the meeting for his part, and then Phil's piece, and then we will start. Ashish, please.
Thank you, Andrea, and thank you, everybody, for joining, of course, in person as well as online. Just to give those of you that might be a little bit new to the meeting, this meeting came out of friendships, and what happened was we were in Houston at the IBCG last year and talking about, of course, response to systemic therapy, and Andrea, in his always wanting to push the boundaries and drive things and move things forward, said, why don't we have a focused meeting on clinical complete response in Milan at the San Raffaele? And of course, as president of the IBCG, all I can say is yes to Andrea. So we did that last year, and it was very well attended, and a publication came out, which is very high impact. So this year we focused on biomarkers in Houston broadly, and here we're focusing, as Andrea mentioned, on liquid biopsies. You will see, those of you who are new to the meeting, and welcome for the first time if you're new. This is a working meeting. We want to hear from all of you. Just chime in. Of course, respect the fact that we're online and in Zoom as well. Press the mic so people can hear you. But at the end of this, there's a deliverable, and the deliverable is hopefully something that can be well-cited, guide clinicians and regulatory bodies into the use of liquid biomarkers in urothelial cancer. So with that, I want to thank Dr. Necki, all of you, and welcome.
Well, much like Andrea and Ashish, welcome everyone. We're very excited on hosting this specific and special meeting on biomarkers. As we all know, this is a space that's getting increasingly important related to clinical care. Many of us in our practices see that we are thoughtfully trying to use biomarkers, but the truth of the matter is we don't have, I would say, clinical experience, expertise, recommendations from global experts, and I think that's what Andrea is exceptional at doing, is gathering thought leaders, and I think this is an incredible gathering. I think we have a lot of opportunity here, setting the stage much as what was done last year and looking at complete responses. The Global Society is very interested and I would say committed to looking at biomarkers. We know the rare cancer space is unfortunately an area where there's probably more questions that there are answers, and I think for many of our rare cancers, we know that the pattern of biology is such that sometimes patients progress very quickly, very unpredictably. There's a huge opportunity for biomarkers to drive clinical care, and I'm very excited in working with all of you. As Ashish mentioned, this is very interactive. This is not one of those where everyone gives a talk. Thoughtful comments, I think, will engage further conversations, and I'm definitely very interested in learning from all of you and working with all of you with what will be probably a very important consensus paper to come from this. So welcome everyone, and looking forward to this meeting.
Thank you, Phil. So I see an increasing number of people and friends connected online and via Zoom. So if you send or if you projected the slide, the introductory slide, I think that everyone is able to see the slide, right? Please confirm, guys, out there, technicians. Are people able to see on Zoom the slides?
No.
Because I don't see the slide shared via Zoom. Maybe if you are able to share the slide for the introduction, so that I will move on. Just to say and to show you the agenda for today. So the agenda is very easy. We'll start first with the science, the background, 3 lectures providing the background of the available data for liquid biopsies, liquid biomarkers in urothelial with Petros, in renal cell with Sarah, and in prostate cancer with Raji. And then we will open up the door to a broader discussion that is more strategic than scientific, you know, when we will cover a lot of issues related to test availability, to technical developments of the test. We will hear from Natera, from EMA guys, and so, and there will be plenty of time for discussion out there. So I don't see my slides. This is the agenda. Next slide. I cannot control. As Ashish has mentioned already, this is the consensus paper that came out from last year meeting. And in particular, I have highlighted a few words that we anticipated last year with regards to the definition of clinical CR. This is, as a reminder, this is a paper focusing on endpoints in bladder cancer for the next generation clinical trial design or bladder sparing approach depending on clinical response to systemic therapy. And in the definition of clinical CR, we anticipated that we discussed quite a lot already last year around the biomarker issue, and we concluded that at that time, December 2024, time was a bit premature to state or to think about incorporating liquid biomarkers into a practical definition of clinical CR to be used in daily practice. We'll see if today we'll be able and shaped enough to incorporate the data that you will hear from our friends into real world, into a kind of recommendation for the community of oncologists and urologists. I conclude the introduction with by spending a few words to thank the organizing secretariat again, as I did yesterday. A very outstanding job in incorporating all the desires, the requests, and so thank you guys for the outstanding work that you did on the background of our work. So let's start with the first presentation made by Petros Grivas, who will provide us with a snapshot with an update of the liquid biomarkers in urothelial cancer. Petros, the floor is yours. This is for advancing the slide.
Grazie mille Andrea, buongiorno, good morning everybody. There you go. Okay. Hopefully now you can hear me. So, grazie mille, Andrea. Thank you for getting the family together. I agree with Assis and Phil that this is a family reunion. And there is so much work coming out of this. So I think the product of that work of last year was nicely summarized by the paper in JCO that just came out in a timely manner. Actually, I got the JCO volume in my home on Tuesday evening, a few hours before my flight here. So it was a good, start of the trip. No, great to see everybody, and thanks again for the great hospitality. I try to take the next few minutes just to get us through the rapid evolution of data in the field of bladder cancer, especially with the use of ctDNA. There is so much to cover. I'll try to do it as effectively and efficiently as possible. These are my disclosures. And of course, there will be some overlap, I think, with Andre's talk from yesterday, just because of the data nature. And by the way, I'm glad to see many friends and colleagues in the Zoom, Andrea. There are many, many friends calling from US and other areas. So obviously, there are a multitude of opportunities for ctDNA applications, not only in bladder cancer, but in general. And just schematically here, just to show you, if we think about ctDNA, there are applications in cancer detection, screening. This is something we have not touched, and maybe in the future, guys, I would like to challenge us all here, and I look at Andrea as well. How can we think about ctDNA as a potential method to enable cancer screening? And this is a play across tumor types. We had a task force, a think tank with NCI recently tried to tackle that trial design. It's not an easy one, but something to think about. In addition to that, there are, of course, opportunities for molecular profiling, right, and understanding the molecular basis of disease, biomarkers, and, of course, prognostication, opportunities for detection of residual disease on the molecular level, therapeutic response, monitoring of response, and with a serial, of course, liquid biopsies, because it's easier logistically to do a blood test compared to serial tissue testing, right? It's much more, I would say, logistically burdensome to serial tissue testing. And of course, there are the angles of monitoring not only the quantitation of ctDNA, positive, negative, and the continuous spectrum of that.
Petros, AV team, the online guests are saying that the slides are not projecting properly. Could you please help them? The slides are blurry and poor resolution. The
Thanks.
folks on
We'll
Zoom
do our
are not
best to
able to see
follow
the
along.
slides
I
properly.
didn't want to interrupt too much, but thank you, Ashish.
Thanks,
Thank you,
Ashish.
thank you, Elizabeth, for highlighting. So, if you're able to condividere dove bisogna condividere le slide su Zoom.
Thanks for confirming. That's a good point. Make sure we follow through.
That's good now.
Thank you. Thanks, Betsy, for pointing it out. So, and let us know, guys, if it doesn't go through, let us know. So there are opportunities, as I was saying, in terms of quantitating the ctDNA, right, positive, negative, and also as a potential quantitative marker, because Alex Wyatt did a great job in the discussion at ESMO, pointing it out that it's not only the dichotomous positive, negative, maybe a gray zone in between that has to do with, the quantitative ctDNA spectrum that might actually give us more depth and granularity of sensitivity. Of course, also there is an opportunity for molecular genomic analysis, mutation profiling, that can enable us to understand the mechanisms of resistance, right? If you can follow molecularly ctDNA, you can get insights on the tumor biology as it evolves over time. So with that in mind, the big question is how can we add value, right? It's a new tool in the last few years. Can we use that to add value for our patients? Is it prognostic? Is it predictive? We can discuss a little bit more about the data today. Does it have clinical utility? Clinical utility is a high bar, right? Clinical utility means if you use a biomarker, a test, an assay, whatever you use, does it add value by improving patient outcomes? And that bar is not that easy to achieve. Analytical validity is one thing that you measure what you're supposed to measure. Clinical validity, whether you can prognosticate, separate the groups prognostically, but clinical utility is a third and highest bar. Can you impact patient outcomes by using the test? And of course, there are logistics, there's cost effectiveness questions, time questions, the burden in a team to ordering a test has to be taken into account, and of course, turnaround time. And if you have a tumor-informed assay, whether you have adequate tissue to generate a tumor-informed assay as opposed to a tumor-agnostic assay. Very briefly, a trip over time here, go back in 2019, before the pandemic, our friends in Denmark generated very important data with ctDNA, raising the hypothesis that this is highly prognostic. And as you see, this is the data from Christensen and, of course, our friend Lars from Aarhus, Denmark. And you see that if your ctDNA becomes undetectable or goes down, there is correlation with pathological complete response. So lack of detectable ctDNA, or let's say ctDNA negative status, correlates with pathologic downstaging and pathologic complete response and better outcomes. Data, again, in terms of time to event endpoints, if you look at recurrence-free survival, you see ctDNA is highly prognostic. ctDNA negative status, much better outcomes compared to ctDNA positive status, and this is in different time points. On the upper row here is data, again, for patients who underwent neoadjuvant chemotherapy followed by radical cystectomy. On the lower part of this slide is data from the Abacus trial that was done with Tom Powles and Bernadette Zabados in UK, and you see similar stories. ctDNA undetectable, much better prognosis, the blue line compared to detectable ctDNA, the red line. And of course, this has recapitulated in different trials. This is the Nabucco trial by Michael van der Heyden and his team. In Netherlands, same story. If you see a ctDNA that is not detectable, higher chance of pathologic downstaging or pathologic complete response, better outcomes, in better survival. So both in terms of path share and time to event endpoints, significant correlation. That takes us to the Niagara trial. Very briefly, we saw the data from Tom Powles last year at ESMO. A year ago, this is a practice-changing trial showing that the addition of perioperative durvalumab to GemCis neoadjuvantly in this trial was superior to GemCis neoadjuvantly in patients with localized muscle-invasive bladder cancer who were cisplatin eligible, and that trial led to the FDA approval and EMA approval of durvalumab perioperatively in neoadjuvant and adjuvant in this setting. There are many questions about the contribution of the phase of therapy, neoadjuvant, adjuvant, or both. And what you see here is ctDNA data from that particular trial. On the left, event-free survival. This is baseline ctDNA at the time of study entry at baseline before treatment. You see ctDNA is prognostic. As you see, ctDNA negative patients do much better compared to ctDNA positive patients, significant difference in the hazard ratio. And on the right, you see the potential, I would say, conclusion that if you have ctDNA negative or positive status, in both of those groups, durvalumab perioperatively appears to benefit the patients. And you see the hazard ratio on the right lower corner. Again, this shows that in ctDNA negative, ctDNA positive patients, in both groups, there appears to be a benefit with addition of durvalumab perioperatively. The other interesting point from that trial that I think contributes to the discussion, if you look at the baseline ctDNA positivity, was 57% overall. It went to 22% after neoadjuvant treatment, and to my surprise, went down to 9% after radical surgery. And Sakrod, we discussed yesterday that ctDNA can come from the distant micrometastasis, but it may also come from primary tumor. So that, I think, it's some generation here of the discussion that resection of the primary tumor or dealing with the primary tumor may impact also ctDNA detectability. And you see that ctDNA clearance was higher with durvalumab addition to chemotherapy. You probably targeted tumor heterogeneity if you add chemotherapy and immunotherapy in that context. And this is ctDNA clearance, 70 versus 57%. Again, durvalumab plus GemCis, more ctDNA clearance. You see that on the left part of the slide. On the right part of the slide, you see again the prognostic role, ctDNA clearance is highly prognostic, much better outcomes compared to persistent ctDNA positivity. Interesting data here, if you have ctDNA, this is a different time point, this is not baseline, this is pre-cystectomy, so if people went through neoadjuvant therapy, chemotherapy alone or chemotherapy plus durvalumab, and this pre-cystectomy ctDNA. And what you see there is, if you're ctDNA negative at that time point, is 50-50 whether you get a path CR or not. So there is no very clear correlation there between ctDNA negativity and path CR. This was surprising to me. On the right, you see that if you're ctDNA positive, the vast majority, 97%, do not have path CR. So ctDNA positive correlates very strongly with lack of path CR in that setting. And this slide, I think, was the most surprising to me. This is an interesting one. This is ctDNA post-cystectomy, after surgery. So neoadjuvant treatment, surgery, and this is post-cystectomy DNA status. 91% of patients were ctDNA negative. And in that subset, if you break down the path CR and the non-path CR subsets, small numbers, small power, it's not conclusive, but the hypothesis here that both of those groups appear to benefit And I say appear because you cannot use more conclusive language. It's probably underpowered. But the curves separate, and the hazard ratio here is 0.4 to 0.54, suggesting benefit with durvalumab in both those groups, again, with a caveat of small numbers. Very quickly, in the last few minutes, INVIGO-010 trial, adjuvant atezolizumab versus observation. This was back in time, a negative trial, no benefit with adjuvant atezo. Classical example how you can learn from a negative trial, right? We went back, look at ctDNA, we published this in Nature. The hypothesis was generated there was ctDNA negative patients, no benefit from adjuvant atezo. ctDNA positive patients appear to have benefit from atezolizumab. So there is generation of hypothesis of not only prognostic, but also potential predictive value. And that brings us to INVIGO-011 that was designed to validate the hypothesis, right? Is it predictive or not? ctDNA negative patients were followed over time. These are the same patient population. Patients who were immunotherapy naive. They may or not have received neoadjuvant chemo, undergone radical cystectomy, and then they went every 6 weeks, and that's a frequency of testing with some testing burden you can argue, but this was the way it was done, every 6 weeks for 9 months, and then a single time point at 12 months. So 9 months, again, every 6 weeks, and then single time on 12 months. If you're persistently negative, ctDNA, you're observed, I'll show you the data. If you're ctDNA positive, either at the beginning or you're converted positive, you get randomized to atezo or placebo, atezo monthly or placebo. The data showed significant benefit for investigator-assessed disease-free survival. In ctDNA positive patients, hazard ratio 0.64, doubling of median disease-free survival, favoring atezo versus placebo in ctDNA positive patients. And overall survival here, hazard ratio 0.59, which by the way was the same hazard ratio in INVIGO-010 trial. So the hypothesis was confirmed that ctDNA can be predictive, not only prognostic, in that with all those benefit with atezo versus placebo in that setting. Now, the patients who benefit from atezo versus placebo were both those who had ctDNA positive test at the time of study entry, but also those who converted from negative to positive later. So both of those subgroups appear to benefit from atezo versus placebo in ctDNA positive subgroups. And people with ctDNA negative status appear to do well, most of them. Is not perfect, but you can argue that a significant proportion, vast majority, do well if they have persistent negative over serial testing. And that's an important point. In INVIGO-010, it was a single time point, and that's why the curve showed some attrition. It was about 30% people who had recurrence in the INVIGO-010 ctDNA negative because of a single time point. Here you have better outcomes because you persistently stay negative. So it's a dynamic marker here, more time points of ctDNA collection compared to INVIGO-010. Very quickly, CheckMate 274 adjuvant nivo versus placebo, positive trial. Nivolumab had FDA approval, all comers in US, only PD-L1 positive patients in the Europe. We saw data, I think Matt presented this data at ESMO a month ago. You see here, again, ctDNA is highly prognostic. As you see, people who have undetectable ctDNA do much better, the blue line, compared to ctDNA positive, the red line, both for disease and overall survival. Again, no surprise here, it's highly prognostic. But the interesting thing here is also the potential predictive value. These are small numbers because only a small proportion of patients, I think less than 20% or so, of patients had ctDNA available data. And from those, the hypothesis here is that it's similar to INVIGO-011. ctDNA positive patients appear to derive benefit from adjuvant nivolumab. ctDNA negative patients appear to not derive benefit. Again, it's small numbers, but the data here corroborate the data from INVIGO-011 to a significant degree with a potential predictive value of ctDNA. Tombola trial from Denmark. This was a little bit different design, not randomized trial. They tried to follow patients over time after radical surgery, and you're ctDNA negative, you were observed, ctDNA positive, you get atezolizumab. So they did that treatment upon detection of molecular residual disease, MRD. And what they showed there is that about half of the patients were ctDNA positive at cystectomy. 3/4 of recurrences were detected in the first 4 months, early time points. And patients who remain ctDNA negative, again, persistent negative status of ctDNA, only 3% had metastasis. Again, in the INVIGO-011 was about 10%. Again, some different assay here. It's not the signature assay, slightly different assay. And about half of the patients met the prominent point of not having disease upon receiving atezo at the time of molecular recurrence. This is, I think, the key, some last slide here. So ctDNA is dynamic. Again, think about it's not a single time point, it's over time that can create some logistical burden, testing burden to the team. But overall, the data are very robust for the prognostic value. Niagara, IMvigor011, Segment 274, Abacus, Nabucco, we have seen that again and again, robust, strong prognostic value. But now we have predictive data. IMvigor011 showed the predictive data, benefit and, with atezo versus placebo, and in Segment 274, benefit with nivo versus placebo, showing that the ctDNA is also predictive. In immunotherapy-naive patients post-cystectomy, it can help us with risk stratification before and after radical surgery, treatment selection, again, in immunotherapy-naive patients adjuvantly, and potential serial monitoring. And of course, we can discuss today further about opportunities for bladder preservation. How can we learn more about chemoradiation, about systemic therapy alone? Can we use that tool to help us in those decisions? And what is the regulatory framework to design the right trials to use it as an integral integrated biomarker to help patient selection? And I think this is an opportunity for discussion. Thank you so much for getting the family together.
Thank you, Petros. Outstanding overview. Thank you very much. Really informative. So let's leave 2 minutes or 3 minutes for burning questions. So if you have any question, please feel free to intervene, sending question on Zoom or.
So Petros, I do have a question for you. 2 comments and a question built into each one of those. You covered muscle invasive and metastatic cancer really well. And we and others have looked at ctDNA in the non-invasive setting, at least T1s. We call them non-invasive, but they're invasive, right? With not good correlation. There was a small series that came out of Cleveland Clinic from Laura Bukovina and Shilpa's group that suggested that patients that have detectable ctDNA with non-muscle invasive disease do poorly. Based on that, I've seen a surge of patients referred to me with a positive ctDNA, unresected tumor, and then put on systemic therapy for metastatic disease. You resect the primary tumor, ctDNA disappears. So one, I'd like to hear your thoughts and comments on that paradigm. The other one, what we've seen, and I don't have access to the data from the large studies, I don't know if somebody does, but when a patient is ctDNA negative, it doesn't correlate with PAT-CR, but it seems to correlate very highly with negative lymph nodes, right? So the primary tumor might still be there, maybe not bladder preservation, but we're always looking to de-escalate. The SWOG study suggested we don't need to take out 100 lymph nodes, you can just do a standard lymph node dissection, but there's still some mortality and morbidity associated with it. Any thoughts from anyone in the room as to can we avoid doing a lymph node dissection on patients who are ctDNA negative?
I can comment briefly, and I want to hear what people think, both here in person and also in the Zoom call. In terms of the non-muscle invasive disease, I think the data, Assis, are very interesting. Laura's data from Cleveland Clinic. I think it's still early days, though, in terms of the therapeutic decision making. I think we have some uncertainties where ctDNA is coming from, because in the Niagara, 13% of patients clear the ctDNA after radical cystectomy. So I think we still need trials to evaluate how can be useful in terms of making these decisions and risk stratification. I think it can help us with risk stratification, but we need more trials integrating that in integral or integrated biomarker. In terms of the lymph node dissection, still I would answer the same way. Personally, I don't. And I'm not a urologist with that caveat, of course, I defer to you guys, but for me, I don't think I would make a decision about lymph node dissection or not based on ctDNA. I don't think we're there yet. It wouldn't impact that particular surgical decision making. If you go for radical surgery, it's a different question, right? Do you do it or not do it? But I wouldn't, in my mind, impact that lymph node dissection point.
So I'll just build up on that question. Petros, do you have time for one question? Yeah.
And I have one.
So I'll just build up on the question asked by Ashish. How about all these treatments are toxic? There's no doubt in our elderly population. In Tombola trial, metastasis was 3% in ctDNA negative patients. IMvigor011, I think it was 10%. Why should we be doing neoadjuvant chemotherapy? Take the bladder out if ctDNA is positive in patients who are going for cystectomy. Bladder preservation is another question. But why shouldn't we be doing that? And then only give treatment to people who have ctDNA positivity.
So a very quick comment, Niraj. Good question. In my mind is I apply the data in the context of where it was generated. So in my mind, if I have a patient in clinic tomorrow or Monday when I go back, and the patient had already radical cystectomy, comes to me with no prior immunotherapy, let's say cisplatin eligible patient, didn't get anything, and we saw EV Pembro got approved yesterday, but let's say patient had surgery last month, and comes to me and they have a, let's say, PT3 and 0, right? And we're discussing about adjuvant nivo cisplatin eligible patient. Let's keep it easy. In that particular patient, I might use ctDNA to inform the adjuvant nivolumab decision because it's relevant to the IMvigor011 segment 7-4 trial. However, personally, I would not feel comfortable extrapolating the data to patients who had prior neoadjuvant immunotherapy. It's a different context, I think, different treatment. So I do not know how the IMvigor011 data apply to EV303 or Niagara because of the different neoadjuvant therapy containing immunotherapy there.
I just wanted to comment that even in the IMvigor011, Ashish, to your point about lymph node metastases, those with ctDNA negative had actually recurred in lymph nodes, and that is what we want to look at, that subset carefully. And the other thing about Petros, the data applies to atezolizumab, but I think we can't do a trial for every neoadjuvant regimen. So I think at some point we should have a consensus on how to apply that information to all these perioperative regimens and avoid unnecessary treatment, to Neeraj's point. And lastly, I think, Andrea, the data you showed at ESMO with the urine tumor DNA, I think that is very exciting and can become, so that would be good to cover that too in this. I know you covered the ctDNA, but
Shilpa, it's almost like you answered the survey we sent out.
Exactly. We will show you the results of the survey that we did with the BCG. So a very short question to Jason, to the radiotherapy guys. Petros, you presented the data from Niagara. If I remember well, there is a 13% clearance of the ctDNA, which is due to cystectomy. 13% more or less. So are you, or is there anyone, or are you, Jason, aware of any data related to ctDNA clearance in the chemoradiation setting?
Yeah, we presented, and that's, I would have just added that to the summary of your last slide, Petros, which is, there certainly is data on the prognostic ability of ctDNA and bladder preservation. We presented on, led by Kent Mao, on 80 patients at ASCO this year, and hopefully that publication is coming out soon. Basically, the majority of patients after TMT were ctDNA negative. Out of the 80 patients, 18 were ctDNA positive pre-TMT, and 8 remained ctDNA positive post-TMT. So the majority were ctDNA negative after TMT, either because they were negative to begin with or they converted to negative. So I think 10 out of the 18 that were positive became negative after TMT. So I think you're seeing kind of a similar phenomenon with chemoradiation as you were. What was the percentage with cystectomy again?
In Niagara is 13% clearance, which could be attributed to cystectomy.
To cystectomy alone.
Yeah,
So that percentage might be a little higher, actually, with chemoradiation. Obviously, these are small cohorts.
Yeah.
They're 80 patients. But I think the prognostic, and there's some other groups that are working on this as well. So I think that data is emerging. I think it's going to be very interesting to look at treatment selection in the bladder-preserving sort of chemoradiation space. Question for you, Petros: what percentage of patients recur, but are ctDNA negative at recurrence, right? Just because of the evolution of the mutational profile. Do we have data on that?
Yeah, great question. And thanks, Jason, for sharing the data by Kent. I think we need, this data for sure, and I know you're working on larger numbers. The answer to your question, if I remember correctly, from the Tombola trial, patients who had negative ctDNA, only 2 patients, 3%, had radiologic recurrence from that cohort. And that number, if you look at the curve from the IMvigor011, the persistently negative ctDNA patients with serial negative tests it was about 88% recurrence-free survival, so about 10 to 12% had an event, recurrence or death in ctDNA persistent negative category.
And it was lymph node metastases, less than 10% in InVigor OVEN 1.
Less than 10. Yeah, and I think what we need to do is combine ctDNA with urine tumor DNA, and that's going to be super fascinating, right? So, and may help guide the use of local therapy, right? So if you're ctDNA negative, urine tumor DNA positive, you need local therapy. If they're both positive, you probably still need local therapy for the phenomenon that you're saying that the primary tumor is shedding, right? And so combining those two, I think, is going to be really, really important.
Because, to your point, recurrences can be, in the urinary tract, right? And even we think about upper tract tumors, I think that the urine DNA, that will be also very interesting there.
Yeah. And do you think ctDNA dynamics are going to influence the duration of adjuvant IO, for example? Are you going to go towards clearance and then stop? I mean, just because the time on IO is so, we don't have great guidance, really.
I think we need more data. Personally, I think in that, de-escalation question, and that can apply to many different settings, adjuvant, metastatic. When do we stop, right? For the moment, I tend to follow the clinical trial data from the, with the caveats that come with it, but I don't think we have enough information yet when to stop treatment. I think it's mostly about starting treatment, but I think stopping treatment is probably a little bit separate question in regards to trial design, but it's a great question, Jason.
Exactly.
Thank you.
I do want to make, my mic's not working. I do want to make a slight editorial comment here, just us being a global society and me being a global citizen. ctDNA clearly we need, even with access issues. I think urinary tumor DNA clearly makes sense, but we haven't proven yet that urinary UTDNA is superior to tumor cells being shed in the urine and measured by cytopathology, which is cheap, readily available, and I know we're jumping on the UTDNA bandwagon, but cytology done well is almost just as good when you look at small cohorts, right? So again, just being cost conscious and looking at the entire world, I think ctDNA, yes, UTDNA, we have to prove it's better than cytology before we automatically assume that that's what we're going to use.
Yeah, great discussion. We will leave the rest of the discussion afterwards in the roundtable debate. We will have plenty of time then to have further comments and questions. For example, we just received this morning, as an example, the result of a pre-screening test that we did on our patient on liquid biopsy for screening in a study with second-generation FGF receptor inhibitor that was positive. So it's not a matter just to need the ctDNA positive or negative, but also to have information on the quality of the mutation. And there will be a great discussion with Andre Cruz and the Natera guys and Jeff and other guys in the roundtable debate. Let's move on now with the renal cell.
Thanks, Andrea. Wonderful conversation. This is exactly what we need. I think this will generate a lot of thoughtful, hopefully, conversation and statements that we generate from this. So the next topic, which I think will be fascinating, Sarah Scagliarini is going to give us an update related to the review of the evidence of circulating tumor biomarkers in kidney cancer. Sarah, thanks for participating in your talk.
Thank you for this great opportunity to be here between two giants, and I have not so important data, but I want to talk about RCC. It is a really great opportunity for me. I am a clinical practice oncologist, so from practice to translation research in this moment with a clinical vision about this data. For me, it's really important. And just one moment to talk about our project. Just 1 year ago, we spread two surveys, one for oncologists due cancer focus, and one survey for patients renal with kidney cancer, and two scored the top 10 priority in clinical research, and both survey that spread that we want to on podium biomarkers both for oncologists and patients, and also therapy personalization. We know that biomarkers are useful for therapy personalization. And at the last ESMO 2025, we have a lot of presentation about this theme, these important topics about minimal residual disease, circulating tumor DNA, but also a great presentation from Professor Anna McKay about emerging biomarkers in kidney cancer. We had a great mini oral session and a little my discussion about this theme, but biomarkers are many things, histologic feature, but also spatial immunophenotype, genomics, and clusters. We know new data about clusters for first-line metastatic renal cell carcinoma, but today we have to talk about circulating biomarkers with the famous KIM-1, but I think that not only KIM-1 for this pathology. We have a great work about role of liquid biopsy in GU cancer, so we can talk about CTC cell, ctDNA, but also RNA, lipids, protein. So really many things from work of Professor Gupta. But about kidney cancer, we know that no FDA approved biomarkers for this cancer, and we know that liquid biopsy show prognostic value, and MRD detection is promising for clinical practice. Another work of Italian colleagues and friends, also Professor Necchi and Brigida, and evolution in these terms about biomarkers in GU cancers, but about renal cell carcinoma, very few data. But we have data about the liquid biopsy for renal cell carcinoma. Is simple. We can have many samples, no complication, no discomfort for our patient, and the use in monitoring treatment or monitoring follow-up for our patient with renal cell carcinoma. Also because we have a problem for renal cell carcinoma, heterogeneity. Spatial tumor heterogeneity interpatient, between patients, but also intrapatient, so from primary tumor to metastasis, and in the same samples of biopsy in primary or in metastatic lesions. So we have many problems for renal cell carcinoma. Also about a mutation. So we have 2 patients with RCC, with kidney cancer, with 2 genomic heterogeneity, and so clinical heterogeneity. It's clear that we can have the same drugs for all patients. We have to understand, I think. And we have 2 immunosystems, 2 players like immunosystem and angiogenesis in renal cell carcinoma. And liquid biopsy can give us also immunomicroenvironment via plasma biomarkers, so interleukin, but also angiogenic CK and soluble PD-L1. We want more to understand, and we know that FDA approved biomarkers for immunotherapy, so mismatch repair deficiency, but also other mutational burden of PD-L1, nothing for renal cell carcinoma. In this disease, but also in other disease, in other cancer, we need biomarkers for early detection, but also post-surgery. For decide about adjuvant therapy, there is a great debate about adjuvant immunotherapy, but also for monitoring the follow-up of our patient and metastatic disease, like a prediction of response to first-line therapy, but also for personalization of therapy, so the escalation, intensification, resistance. So we need biomarkers in renal cell carcinoma. Professor Anna McKay say that about localized RCC, not ready from prime time. We have not data about that. But we have to do more because some data there are in this moment. This is one of the most important work of Korea with 45 patients, and we have a patient with surgery for renal cell carcinoma. We had the preoperative ctDNA with a detection in 50% and postoperative ctDNA with detection in 27%. There is a great correlation in this case from with a size of tumor and a trend in grade of tumor. And we have a trend towards overall survival, but we have a great correlation in relapse-free survival after surgery with a monitoring of ctDNA. So we can do more in this moment. And about this comment of Dana-Farber team, we know that we have a historical tumor agnostic assay with a 40% detection, but if we have a bigger samples, 20 patients, we have a detection of 71.8%. So we can have more information also about if2 alpha activity, but also sarcomatoid differentiation. And we have a correlation in CTC cells with TKI therapy and the median. So I think that there is a lot of data to begin a new study, new randomized study. About metastatic patient, we have this work of Professor Pal in 12 patients with an interesting bespoke assay. So we have in this case tumor sample, but also liquid biopsy. And we have information about the mutational situation for our patient. And we have in this case a whole genomic signature, not only whole exome signature. And this is the difference, more important in my opinion. And in this case, we have a great correlation with response. So an important correlation between complete response and partial response, but also with progression disease and response. So if you want to monitoring a patient with the ctDNA, you can understand if your patient is in response or in progression, so to intensification or the escalation of therapy. And we can have more information like mutational status for RCC, for example, PBRM1, that is a prognostic factor that we can add to other prognostic factors that we have. And this is another important work, in my opinion, because epigenomic signature can give us more information about sarcomatoid differentiation thanks to FOSL1 positivity. So a migration from epithelioid to epithelial mesenchymal transition, and also important information about prediction of response, because we know that in this case we need immunocombination therapy, not only TK1. So there are a lot of things to do. Is a really important biomarkers for immunotherapy benefit in this case. We have two only poster, thanks to Marzia from ESMO, about this important data, not only KIM1. And in this case, we have a study with two cohorts. Cohorts are with patients with the resection of primary kidney cancer, and then metastatic renal cell cancer. And also in the phase 1 cohort, we have a correlation with a relapse. But also in metastatic renal cell carcinoma, we have data to prognostic evaluation, but also to response to the first line treatment. So there is a great correlation. Another study, many patients with bespoke tissue and liquid biopsy in this trial, and also metastatic renal cell carcinoma, a longitudinal ctDNA MRD monitoring, not only minimal residual disease after surgery, so understand adjuvant therapy or monitoring follow-up, but also during treatment, because we know that we have immunocombination therapy and we want to understand if we can de-escalate the therapy for our patient, in particular for TKI with a great toxicity. And there is a great correlation, so we can do more also for migration information. We have a great work presented by Professor Pal about tissue and migration for drug pressure, so we can do more. And about urine are biomarkers. I have this work, Professor Beck's, with the glycosaminide scores after surgery to understand the relapse risk. So in this case, we have a great correlation with these simple biomarkers. And finally, the KIM1, the superstar of biomarkers, with great data about early detection of kidney cancer, but also many data about relapse risk and benefit to atezolizumab in adjuvant therapy, and great data also in metastatic renal cell carcinoma in great randomized clinical trial for the principal drugs for our patients. So we have more retrospective data, but I think that it's the moment for a randomized clinical trial. In this case, we have the first Chimera trial. Liquid biopsy, EP-Nivo 1, the first cycle, then the new liquid biopsy to understand if this is the right treatment for our patient. When we have unfavorable KIM1 ratio, we can start also randomized 1-to-1 IO-TKI immunocombination therapy, because we feel more risk for this patient. Then I think we need an integration of biomarkers for renal cell carcinoma in this moment with the randomized clinical trial, also with the help of pharma. I think in the same great study, international, because we need more patients, a lot of patients for real data. We can have many questions, but many answers in the same randomized clinical trial for the future, imaging, but also biomarkers and drugs. Thank you very much.
Thank you, Sarah. Great talk. Is there any comment, any question?
That was a great presentation, a lot of going in kidney cancer. At ESMO, there was another presentation called MADCAM from the Javelin kidney trial. I think it shows promise as prognostic, but I was wondering what you think, because all these negative trials are generating good data from the studies.
It's really... it's my thought that it's strange that we have many data from negative trial and few data for positive trial. I think that we have to do more, and it's in this moment we have a prognostic evaluation for these data, but integration also with the microbiome is, in my opinion, is really important for the future.
Sarah, that was a wonderful talk. 2 questions or comments. The ones surgically that I think we find challenging is, I mentioned it yesterday, is the adjuvant conversation. As obviously, it's an emerging area, but I do think we are stuck with, I would say, indications that indicate we should offer it to our patients, and oftentimes we see toxicity. So thoughts related to obviously use of biomarkers. I think this is an ideal setting where it can sort of be adjunctive to using clinical parameters, which we know sometimes don't really capture this highly heterogeneous disease. And the other one is, you know, we don't do many today, but cytoreductive nephrectomy, when those patients have a really great response, we still see a little bit of residual disease. You know, could we use biomarkers to help drive the true decision where the local disease may be really the driver versus systemic progression? Thoughts on those points?
In this moment, I think that we have to use indication of pembrolizumab adjuvant therapy, so TNM. But we have to do more for patient. Yes, toxicity is important, but we have to know more about relapse risk, also thanks to biomarkers, not prognostic like nomogram, in my opinion, is really sure, in my opinion. So we have to do more, because we have a TNM classification that is really large for me.
Jeff.
Renal cell carcinoma is the enigma of genomic profiling. Unlike all of the major cancers we deal with, lung, prostate, colon, breast, pancreatic ductal, this tumor is driven by loss of tumor suppressor gene function, not dominant oncogenes. That's why there's so few targeted therapy options, because how do you restore the expression of a deleted, mutated, or even methylated tumor suppressor gene? We have some glimpses coming forward. We know about TP53, Y220C, and the Risatapop, the drug that restores TP53 function, having efficacy and getting an FDA approval, in fact. What are we going to do about RCC, especially clear cell? A little more information comes out of sarcomatoid, but chromophobe, clear cell, papillary has some things like MET that we talked about yesterday. I'm not sure where we go. I mean, using biomarkers for prognosis, for changing systemic therapies. We don't even know why immunotherapy even works in RCC. None of the biomarkers we use for lung cancer, for example, apply to RCC. The patients respond or don't respond for other reasons we can't figure out. We thought PBRM1 loss by deletion or mutation was going to be the explanation. And of course, follow-up studies did not validate the original one. How do we restore tumor suppressor gene function? Because that's the only way we're going to have systemic therapy that can assist immunotherapy for RCC. And for monitoring, absolutely it works. And the heterogeneity issue, I think we've always remember the first heterogeneity will really limit genomic testing came in renal cell. When the New England Journal said every metastasis site's got a different profile, and the primary tumor's got 6 or 7 different profiles. Wonderful paper, wrong conclusion. That tumor was driven by a SETD2 and a VHL truncal tumor suppressor gene loss, and it was present in every single sample they tested, and then they said there was heterogeneity. That said there wasn't heterogeneity, and there isn't for the drivers. These are all additional mutations, but they can be tracked and help guide therapy for sure. But what are we going to do about not having any targeted therapy for RCC? And I'm not really sure.
Thank you, Jeff. Andre, is there any Signatera ctDNA, personalized ctDNA data in renal cell?
Yes, we do. We have the trials that was presented just now. Basically, the genome is the one that provides us the best prognostic information. We have also the observational from all exome. But in fact, the one that was presented now with genome gives us more information. And that's the way the company is paving the route, not only for renal, but also for other histologies. For Europe, we can discuss that later, but yeah.
That was my question, actually, about the whole genome versus whole exome.
Exactly.
It seems to be that depth of the whole genome sequencing may provide more sensitivity.
That would be a great discussion, point for later, yes. Sarah, to close the door for renal cell for the moment, do you think that there would be an added value of adding ctDNA information over KIM1? Or, again, here the issue, it comes the issue of integrating multiple choices, you know. FGF receptor detection for bladder as compared to ctDNA, different purposes, different use. Again, here, KIM1 or ctDNA, what do you think?
I think that for KIM1, we are ready to start with randomized clinical trial because we have a lot of retrospective data. For ctDNA, I think that we have to do more in randomized clinical trial for drugs or by pharma, I think. Then we can start with randomized clinical trial because we need more information in a bigger sample. I think there are a little samples in this study, 50, 40, and not in international evaluation.
Okay, let's close the door for this first round with the prostate cancer. So I leave the floor to Neraji for providing you with an overview of prostate cancer field. Please.
Thank you, Andrea. Again, thanks. Fantastic meeting so far, and thanks for having me present this. So the task given to me was to talk about key circulating tumor biomarkers in clinical use in prostate cancer. So I'll be talking about the biomarkers which are in clinical use, and then I'll talk about some investigational biomarkers. This is my conflict of interest. So let's look at this picture. We have seen this picture shown by Petros, Dr. Scagliarini, if I can pronounce it well. Thank you so much. But let's focus on the left side of the picture first. And this is not only ctDNA. Petros showed ctDNA, which is fantastic, a lot of data coming up in bladder cancer. But I just want, for the sake of completeness, I wanted to show different aspects of circulating tumor biomarkers. So this is DNA, RNA. Within the DNA, we are talking about genomics, methylation, fragmentomics. RNA, we include microRNA, transcriptomics. Then we talk about lipidomics, proteomics, and of course, metabolomics. And then whole cells, circulating tumor cells, CTCs, looking for splice variants, and CTC count, and there's so many other circulating tumor biomarkers. So it's not only cancer. So let's talk about localized prostate cancer. First, I'd like to talk about what is in clinical use right now. So these are the 3 tests which are approved in clinical use for localized prostate cancer. One is PCA3, second is Prostate Health Index, PHI, and one is 4K score, which is a blood test. So these are the 3 tests which are currently in clinical use. So let's look at PCA3. What is PCA3? This is a urine-based molecular assay, and it basically uses a PCA3 mRNA to guide repeat biopsy decisions. So if somebody has elevated PSA level, whether to use biopsy or not, this is an FDA-approved test. So elevation of PCA3 mRNA can guide us towards biopsying a certain given patient. The second one is Prostate Health Index, again, localized prostate cancer setting. This is a combination of total PSA, free PSA, and pro-PSA to help decide on the biopsy. And this is FDA approved, and this is especially relevant for those patients who have a PSA which is not very high. They are contemplating biopsy, and they're not sure whether they should do a biopsy or not, and a rectal examination is negative. And in those patients, if PHI index is high, I lean towards biopsy. I'll be honest with you, I don't use this test very commonly, but this can be helpful in patients who have a PSA level which is borderline, 5, 6. This is the 3rd FDA-approved test. 4 kallikrein proteins are tested, free intact PSA HK2, and you just combine them. And if you have to combine them with other tools to decide whether a patient should get a biopsy or not. So moving on to so this is a summary of all the localized prostate cancer tests I just mentioned. So this is a utility, sensitivity, specificity, and these are the references. Now moving on to the advanced prostate cancer. So this is a snapshot of what we are looking at, CTC, ctDNA, which are on clinical use. So let's look at the CTCs first. So circulating tumor cells, we know in MHSPC, MCRPC, if circulating tumor cells are high, that's a bad prognosis. We have shown that in SWOG 1216, and then there are other papers in MCRPC. There are several other papers. I just picked up these 2 papers. So if you have high CTC, that's a bad sign. If you look at the SWOG 1216 results we published here, the chances of likelihood of achieving a undetectable PSA response was much lower if CTC at baseline were higher. And this was published in Clinical Cancer Research. Amir Goldkorn led the study. So again, baseline CTC is associated with poor response as well as poor prognosis in MHSPC setting. In the MCRPC setting, we looked at the data in SWOG 0421 trial, docetaxel plus minus atrasentan. And same story, if the CTC count is high, that's a bad news for the patients. So this is a summary of multiple MCRPC study looking at the CTC count and the prognostication, abiraterone, enzalutamide, and docetaxel. And all of them pretty much tell the same story, high CTC is a bad news. Now, what about conversion of the CTC? So CTC is high, but it becomes undetectable. That's a good news for the patients. So we just recently looked at TALA-PRO-2 trial. We published this we presented it in ASCO 2024. Regardless of whether patients got enzalutamide or enzalutamide plus talazoparib, if CTC converted from positive to negative, That was a good news in both arms. So survival was much higher, and that basically portends a good response to the therapy. Now moving on to CTC transcriptomics. This is a fantastic paper published by Nima Sharifi and team in Cancer Discovery. So if you look at the CTC RNA sequencing, that can actually show which patients were going to have neuroendocrine differentiation. So patients more likely to develop neuroendocrine differentiation or lineage plasticity were indicated by the CTC RNA sequencing. Another similar paper on the right side, again, CTC-based neuroendocrine gene profiling was able to identify a neuroendocrine phenotype in these patients. So the way I look at these applications, if you have these signatures, then I will follow these patients more aggressively with CT scans. And of course, these data need validation, but they are rapidly going for clinical use, hopefully next 2-3 years. Now coming to the ctDNA, we have seen a lot of ctDNA-based discussion by Petros and Dr. Scagliarini. Sarah? Yeah. And again, this is ctDNA. So ctDNA-based data, we can see, we just looked at the TALA-Pro2 trial, the baseline ctDNA. If it was high, that was not a good news. And ctDNA was also can be used for NGS testing. So I will take a step back and talk about this fantastic paper by Alex Wyatt. Who should have ctDNA testing? So on the right side, this is a freely available website on the internet, and you have to plug in some numbers. Patients have liver metastasis, what is a cfDNA level, PSA. These are readily available tests, and these are all in clinical use right now. So if that test predict that ctDNA is going to be present in the blood, then you should go ahead with ctDNA testing. Otherwise, patient is going to get billed for $5,000. If ctDNA is negative, it's not going to help. So on the right side, that is a freely available tool. You can go and plug in the numbers, and then if ctDNA percentage is high, then you should, the lower one, if you look at the plus sign, then you should go for ctDNA testing. If it's negative, then we should go for tumor tissue testing. So I personally find it very helpful in some patients where I suspect the ctDNA level will be low. So this is a summary of the TALA-Pro2 data, ctDNA level as prognostic marker. If ctDNA level was high at baseline, obviously you can see in both arms survival was, the PFS was lower, and if ctDNA at baseline was high, and at 9 weeks it became low, that was a good sign. So if the ctDNA level is high at baseline, but lower at week 9, that's a good news for the patients. So again, very similar, and we will be publishing this paper very soon, but this was an abstract form in ASCO 2024. Similar data from lutetium PSMA trial. If ctDNA fraction is high, that's a bad news. And going beyond signaling inhibitors, immunotherapy, we looked at the ctDNA use in detecting MSI high patients. This was with Pedro Barata, Oliver Sartor, and we saw that ctDNA can be used to look for MSI high status. And in TMB high, Jeff showed fantastic data yesterday that TMB high status can be determined by ctDNA, liquid biopsies, and those can be used for clinical decision making, knowing how difficult it is to biopsy these patients. So this is a summary of the FDA-approved biomarker-guided therapies in prostate cancer, and for all of these, ctDNA can be used. So whether you look at TALA-Pro2 trial, talazoparib enzalutamide, and then many other trials with the PROfound trial, the first one, all of these can use ctDNA testing for decision making. This is the clinic. So far I have discussed the clinically used biomarkers which are in clinical use now. Let's go to the investigational biomarkers now. So these are the emerging biomarkers, so circulating microRNA. These are the small non-coding RNAs which can be detected in blood and urine. These are highly expressed and very stable. And these are some of the markers which can be used. Currently, these are just investigational, small studies, so I won't take much out of it, but I will keep an eye on these biomarkers. Something which I found was very intriguing, which called fragmentomics. So ctDNA fragments are unique for cancer. So I'm thinking about these biomarkers as somebody will be going for screening for these blood tests. And if there are certain type of fragments which are present in the blood, then I'll be going for tumor detection with CT scans and PET scans. So I think these biomarkers are quickly emerging as not only to see the tumor evolution, but even those patients who don't have tumors, and they can undergo these testing and see if they need to undergo further testing. So again, the extent of use is unimaginable right now, but definitely we'll be seeing more action in this field. Methylation of cell-free DNA, another quickly emerging area of investigation and hopefully clinical use. So some DNA methylation patterns are unique for metastatic sites. So you talked about, Sarah, heterogeneity in the tumor, intrapatient, interpatient, and DNA methylation pattern actually can tell us how tumor is evolving. And so basically to conclude, we have these in-use biomarkers in clinical use, and then we have are using ctDNA for homologous recombination pair mutations, TMB high, MSI high mutations. And we are using CTC baseline, CTC conversion, ctDNA clearance regarding how we talk to our patients in the clinic, how they are doing, how often I should be doing CT scans. If I don't see conversion of CTCs, I'm going to rely more on CT scans more often. If I see CTC level or ctDNA level have completely cleared, I'm going to not do so many scans. I think patients are going to do well for a long time. So it is already helping me. And of course, there are many other therapies, many other testing which are evolving, like methylation, fragmentomics, and so on, which is going to make the whole field very exciting in the near future. So thank you.
Rajan. Another outstanding talk. So is there any burning question or comment?
Neeraj, thank you for that and great work with your studies. I have a question. CTC came out almost 15 years ago, never really took off in practice. And so you are using CTCs, looks like, to decision making. Would love to hear what platform, and also other question about ctDNA. Are you using it when you use PARP inhibitors to see if they develop resistance mutations, and what?
So the answer is yes, we do use CTC and ctDNA both. We order ctDNA levels. Everybody in my clinic undergo NGS testing for tumor tissue, and with the liquid biopsy in prostate cancer, tumor tissue can be unproductive if the biopsy was done 5 years ago on a localized tissue. Most of the time we get rejection even with foundation medicine, that the tissue may not be viable. So answer is yes, we are doing it. And but I'm really looking forward to these newer tests. I think Natera is what data you presented with IMvigor011 is fantastic. But we are using Natera testing to assess response to radium and nivolumab. We had a phase 2 trial going on, just finished accrual. Hope to publish the results of those trials. Ben Mon led the trial at Huntsman. So I think answer is yes, we are using it, but it so far is only helping us with prognostication and patient counseling. And as I said, I somehow decide how often I'm going to see my patients in my clinic and how often I'm going to do CT and bone scans if CTC count don't convert or if ctDNA level are still persistent. Not as much for treatment selection so far.
So Neeraj, you do both CTCs and ctDNA, is that right? You do both?
Yes.
Or
Yeah.
Interesting. Yeah. And which platform?
Historically, so ARUP lab, they contract, and one was the California-based lab. Whereas I'm there are so many other labs. I don't want to pick up for CLIA certified lab, NGS testing, there are so many great labs. So I don't want to name one lab, but definitely we see some utility.
And you get reimbursed, or no reimbursement issues, right, with CTCs?
Not for CTC,
Again, I have the same comment that I did for renal cell and blood. I'm sorry. We as a European or Italian investigator are very much struggling every single day against the impossibility to get a certain test, a certain companion diagnostic test that is not approved. So the need to have the quantity and the quality of the information that you may get at a certain point simultaneously for the benefit of the patient. So the quality of the mutation and the quantity, it's a matter that recur in all the tumor types. Maybe a matter of full discussion later. Giorgio, do you have a
Just
question?
a comment and one question. The comment is that thanks for presenting data on the localized setting. I think the MRI killed the biomarkers there, so in Europe at least we don't use FI or all these tests. They have been replaced by MRI. And the question is related to the use of ctDNA in CRPC patients when you have the suspect of a neuroendocrine differentiation. Do you think it can still work even if it is not anymore an adenocarcinoma? And are we able to detect this kind of patients and to decide whether to administer platinum or other therapies which are not in the, let's say, common pathway of metastatic castration-resistant?
So you are asking about CTC? Yeah. So to predict who is going to develop neuroendocrine differentiation is a critical requirement in the clinic. Once they develop neuroendocrine differentiation, the disease is so aggressive that many of these patients don't even respond to treatment by the time they are starting chemotherapies. Liver metastasis has already, has really emerged. So I personally think it is extremely important in future to predict who is going to develop neuroendocrine differentiation. And by the time they are developing neuroendocrine differentiation, it may not be clinically obvious. Can we treat them early on so that they don't lose their performance status, they don't develop visceral metastasis? And I think I personally feel very enthusiastic about some of the seminal work done by Josh Lang, Nima Sharifi, and many other stars in the field about the use of potential of CTC as something which can be used to predict neuroendocrine differentiation. So CTC transcriptomics that can be used for predicting neuroendocrine differentiation. Did I answer your question? Yeah. Okay. So CTC can be used, and Jeff, one more thing.
Yep.
Amir Goldkorn, I don't know how we have published or not. Within the CTC, they can use the RNA expression from the CTC. So CTC is not gone. The enumeration of CTC may sound like an ancient thing, but I personally think CTC still has a lot of appeal as far as CTC-based transcriptomic data is concerned, CTC-based genomic data is concerned, splice variant, for example. So I feel very optimistic about CTCs.
Especially the neuroendocrine.
Yeah.
Yeah, I wanted to comment about this. I mean, for years we used synaptophysin and chromogranin expression by immunohistochemistry as defining neuroendocrine differentiation in prostate cancer biopsies. And we know that we see them even in Gleason 6 and 7, we can get staining. And then maybe in true neuroendocrine, we get more staining. More recently, the feeling has been you need to see TP53 and RB1 co-mutation for the formal genotypic diagnosis of neuroendocrine. And it can emerge in a prior acinar carcinoma with wild type for both genes. Later, the obvious histology changes and the mutations accrue. So I think we need to be more specific about what we mean by neuroendocrine differentiation, and it should always, of course, have a very high Gleason score.
Absolutely. And treatment varies. If it's pure neuroendocrine differentiation, carboplatin plus etoposide. If it is neuroendocrine differentiation in the presence of prostatic adenocarcinoma, then we use taxane plus carboplatin. So again, even treatment varies. So I think it's good to know if it's pure neuroendocrine, small cell versus adenocarcinoma evolving into neuroendocrine.
And the RB1 TP53 co-mutation is what will differentiate those two.
Okay, yeah.
I think in the interest of time, we'll move on to the next session because this is the true roundtable discussion that we're all going to have. I think we had great lectures, like almost state-of-the-art from Petros, Sarah, and Dr. Agarwal. Did I pronounce that correctly? So the next session really...
I liked Andrea's Naraji.
What pronounce do you prefer, Niraji?
That's another discussion, right?
I'm playing on.
I was challenging myself by making sure I pronounce your
There you go.
Scagliarini.
That will be part of the report that we publish.
So for the next session, we're going to, like I said, have the roundtable. Andrea is going to present the consensus statements that were voted on, sent out through the IBCG platform. We're going to hear from Andre. But before we do that, we're going to kick it off with Matt Galsky, who's joined us virtually. Hi, Matt. Wave if you can hear us. Great. So Matt's going to kick it off by talking about the MODERN trial, which, of course, we're all familiar with, and its implications for regulatory and future strategies. So let's get Matt going and kick it off. Welcome, Matt.
Thank you. Great meeting so far. Thanks for having me. Let me get my slides up. I'm not going to try anyone's name in the meantime. Let's see. Okay, maybe a nod or a thumbs up if you can see my slides.
Yes.
Okay, all right. So thanks, everyone. Hopefully what I'm going to say is not going to overlap too much with Dr. Grievous. I'm going to focus on the MODERN study and how we thought about this initially and how our thinking has evolved, and maybe touch on some higher level concepts as well. So as we started thinking about designing MODERN, and we think about these issues every day, we really started with the problems that we need to solve as a field. And one of these problems, of course, is how do we avoid giving systemic therapy with a risk for toxicity to patients who don't have cancer, right? That's certainly something that we want to avoid. Patients who have been cured with surgery already, plus or minus neoadjuvant chemotherapy, we should not be giving those patients any treatment that has the potential for harm, because by definition, we can't improve their outcomes further. We also want to ensure that if patients aren't treated immediately after surgery, that there is a period, that there's a curative window that we can intervene that doesn't close if we're going to monitor patients without treatment. We want to improve our ability to screen novel treatments in the adjuvant setting, and I'm going to circle back to that, but I think we probably don't talk about this part of ctDNA technology enough. We want to increase the efficiency and speed of our adjuvant studies. And at the same time, we need to balance pragmatism with interpretability and generalizability, because our field's changing fast. In this last bullet point, I think about on a daily basis now, and it's almost like our trials have become a subject of similar problems that model systems experience. And there's that famous quote about model systems that all are flawed, but some are useful. And I think we see the same thing with clinical trials. We can't design a perfect clinical trial, but I think most of the trials that we design are helping to answer at least some questions applicable to some patients. So I'm going to talk a lot about ctDNA testing using Signatera today, and the reason that I'm doing that is because that's where most of the data has evolved, and that's what we're using in MODERN. And we're using that for a number of reasons, both practical reasons, again, because that's where the data that's the platform with which the data was developed that guided the development of MODERN. And it's also a platform that's extremely, that's in widespread use and analytically validated. And of course, those are all the things that we need when we think about doing phase 3 studies. So I can talk a lot, and others can talk a lot in the audience about other assays, different approaches, the attempt to do better and better. And I think we're seeing that with assays that are coming, but we always have to come back to this issue that development of biomarkers are difficult, and analytical validity and clinical validity is difficult. And when you already have those, it's hard to switch gears completely to another assay in terms of trying to establish then clinical utility. So the adjuvant setting, of course, is where ctDNA in urothelial cancer has been developed most extensively, and that's both for practical and clinical reasons. And the adjuvant space, of course, is very unique. This is a situation where we don't have any cancer that we can measure on a scan, and we're trying to decide whether or not we should give individuals treatment. And it's been somewhat unique in urothelial cancer as well, because we had 3 studies that were running at around the same time, testing a very similar question, and those studies yielded different results. Of course, IMvigor10 didn't meet its primary endpoint with atezolizumab. The Ambassador study showed an improvement in disease-free survival, and Checkmate 274 showed an improvement in disease-free survival. So we have these different studies that were designed pretty similarly with some nuances, not exactly showing the same thing. And this, of course, raises the question whether or not the difference in these studies was one just of trial design. Is it the difference between drugs, or is it a more fundamental problem with the difficulty of developing drugs in a situation where some of the patients who are enrolled on the study actually don't need the treatment at all? And I think that's been, of course, one of the explanations for these results. And I think in retrospect, we know that's an explanation for the results because what happened with regards to ctDNA testing in that setting. So, of course, I know everyone in this audience knows what I'm talking about when I talk in those terms. But to make this very simplistic, of course, when we think about the adjuvant setting, we have all these patients. This is the Checkmate 274 data. So, of course, we have these patients on the placebo arm who never had evidence of recurrence of cancer, and those patients were cured with surgery already. And those patients don't need any treatment, and we can give them all the treatment in the world, and the only thing that we do is increase the risk for harm, but we can't help them from a cancer standpoint. We also have those patients at the top, unfortunately, who absolutely need adjuvant treatment, but they don't benefit from the treatment that we're administering them. And then we have those patients in between who both need adjuvant treatment and benefit from adjuvant immune checkpoint blockade. And threading that needle is difficult. And if you have different proportions of patients on different trials in these different buckets, then one trial might read out differently than another. And of course, that's where we need biomarkers. But we have a double biomarker dilemma here. And I think a lot of you have heard me say this before. And so, sorry if I'm being repetitive, but we have a double biomarker dilemma in the adjuvant setting. And sometimes these concepts are conflated, but they're actually 2 different things. So one, we need to know who needs treatment. In the metastatic setting, we have a single biomarker problem. We have a bunch of drugs. We don't know which drugs work the best in which patients, but in general, we know that everyone needs treatment. In the adjuvant setting, not only don't we know what drugs benefit which patients, we actually don't know who needs treatment at all. And this is complicated because these concepts are linked. You can't benefit from treatment if you don't need treatment, but you can need treatment and not benefit from treatment. And so I think ultimately there's probably 2 different sets of biomarkers needed to answer these questions in complementary ways. But we need to start by defining who needs treatment. This can be considered the difference between prognostic and predictive biomarkers, but frankly, I think that sort of cheapens the value of biomarkers that determine who needs treatment in the adjuvant setting, because this is not simply about prognosis, it's really about directing treatment decisions. So of course we know from IMvigor10 that if you use the Signatera assay and apply that retrospectively immediately post-surgery, then you can identify or you can enrich patients who benefit from adjuvant atezolizumab versus observation, whereas if ctDNA is undetectable at that time point, then it was more difficult to show a benefit with atezolizumab. The other thing we know from IMvigor10 is that if you have detectable ctDNA immediately after surgery and you receive atezolizumab and you clear that circulating tumor DNA, then that's associated with much better outcomes in terms of time to event endpoints. And this, of course, is a very important observation. And it's important observation for a number of reasons with regards to drug development. One, it really raises the concept of whether or not we can use ctDNA clearance as a method to screen novel therapies in the adjuvant setting, which we've never been able to do before. We'd had to do large randomized studies with time to event endpoints, wait years for outcomes, and essentially just take the same drugs that we were giving in the metastatic setting and move those earlier to the adjuvant setting. Whereas from a biological standpoint, the drugs that work in the adjuvant setting might be completely different than the drugs that we're developing in the metastatic setting. So this really gives us something to measure, to be able to screen in smaller studies and prioritize what we're moving into the larger randomized studies. And of course, we need to test this concept. This is a concept, but it's a concept that we need to start testing. And of course, the FDA has weighed in on this, the US FDA that is. And you see in their draft guidance in these sections labeled C and D, their high-level thoughts about the use of ctDNA as a measure of response, so to screen the activity of novel therapies, and then as an early clinical trial endpoint. So essentially says, yes, let's take a look and see if we can use this to screen the activity of new therapies in the adjuvant setting, not ready to make regulatory decisions, approvals of drugs based on this endpoint, but important to start to generate the data to determine whether or not we can do that in the future. And these are all concepts that we were thinking about when we designed Modern. So this is the design of the Modern study. This is a study that's being done through the U.S. Cooperative Group System through the Alliance. And this study enrolls patients with high-risk urothelial cancer after radical resection. You can see the pathological criteria for enrollment here. After surgery, patients are pre-registered and they undergo central ctDNA testing using the Signatera assay. If they have detectable ctDNA, they're randomized to standard of care adjuvant nivolumab versus the combination of nivolumab plus relatlimab. In this ctDNA cohort, this randomization involves a seamless phase 2-3 trial design. The phase 2 endpoint is ctDNA clearance. The phase 3 endpoint is overall survival if we meet the criteria to expand to the phase 3 portion. We're trying to test a number of concepts here. Can we escalate treatment and improve outcomes further in patients with detectable ctDNA after surgery? Can we use ctDNA clearance as a gate to decide whether or not we should test a novel therapy in a larger patient population? And can we develop the evidence that links a higher proportion of ctDNA clearance with better time to event endpoints, potentially supporting or adding to the knowledge base about whether or not ctDNA clearance could potentially serve as a regulatory approvable endpoint at some time in the future? In patients with undetectable ctDNA, those patients are randomized to standard of care adjuvant nivolumab or to surveillance with the option to initiate nivolumab if there's molecular conversion from undetectable to detectable ctDNA. So Modern started enrolling about 1.5 years ago. Of course, the field has continued to march on. That's an incredibly good thing. Some incredible advances here on this slide, but it also requires us to think if the questions that we're asking are the right questions. Do we need to tweak those questions, and how do we future-proof trials? So what I'm referring to specifically, of course, are the results of the Niagara study, which showed that if you add durvalumab to neoadjuvant treatment, that improves outcomes. And of course, more recently, Keynote 905, enfortumab vedotin plus pembrolizumab improves outcomes when given in the perioperative setting in patients with muscle-invasive urothelial cancer who are eligible for cisplatin-based chemotherapy. And then, of course, we have the IMvigor11 results as well. So in the last few minutes, I want to contextualize Modern in the setting of these recent readouts, and then I'll finish up. So we amended Modern in early 2025, recognizing that these changes were coming. And so Modern does now allow patients who have received neoadjuvant EV-Pembro, EV-IO rather, and it includes patients who received cisplatin-based chemotherapy plus immune checkpoint blockade in the neoadjuvant setting. I'm going to circle back to that point, but I want to touch on IMvigor11 as well in terms of how that impacts how we think about Modern. So IMvigor11, I think you heard about it already this morning, just very briefly, the study that tried to replicate the results of IMvigor10 from a ctDNA standpoint and establish clinical utility for ctDNA testing. So IMvigor11 enrolled patients with high-risk muscle-invasive urothelial cancer after cystectomy. Patients after cystectomy had ctDNA testing. If they had detectable ctDNA, they were randomized to adjuvant atezolizumab versus placebo. If they had undetectable ctDNA, then they had serial ctDNA testing every 6 weeks, and if they converted to detectable ctDNA, then they entered that randomization. There are a few nuances to the study and how it was presented And so I want to tease that out just a little bit because it's relevant to modern. So a lot of these numbers are derived from the consort diagrams and from some of the figures in the paper because the data is not discussed in this way in the presentation or the paper. But 607 patients were enrolled. 459 had undetectable ctDNA on that test immediately after surgery. 148 had detectable ctDNA on that baseline test. And then among the patients with baseline undetectable ctDNA, about 22% of those patients converted to detectable ctDNA during the follow-up period, and about 18 developed metastatic disease prior to having an assay that converted to ctDNA detectable during that 12-month monitoring period with ctDNA. As we heard earlier today, there were some recurrences that happened after that monitoring period, so after ctDNA was no longer being assessed on that Q6 weekly basis, but about 4% during that year. Here's the results of atezolizumab versus placebo in patients with detectable ctDNA separated out by the individuals who had immediate ctDNA detectability on that first test after surgery versus those who had ctDNA detectability later. And you can see here that there's a benefit with atezolizumab versus placebo in both of these situations, both in terms of disease-free survival and overall survival. In patients who had ctDNA detectability at a later time point, there is sometimes comments made about the effect of atezolizumab being even greater in that situation. I do want to remind people that that includes removal of patients who develop metastatic disease prior to ctDNA detectability. And while that's a small subset of patients, the cohort isn't huge either. And so this is removing maybe some of the patients with potentially the worst outcomes from this analysis because they weren't included, because they couldn't be included in the randomization. The other thing about the survival curves on the bottom is that there's a little bit of a guarantee time bias issue here. Of course, you have to live long enough to be entered into the randomization for entering at these later time points with ctDNA conversion at a later time point. All of that said, some incredibly important information here. One, establishes clinical utility for adjuvant immune checkpoint blockade in patients with detectable ctDNA. And two, really for the first time in our field, defines a new clinical disease state, a molecular recurrence that can be intervened on in a meaningful way with an improvement in outcomes with an intervention versus placebo. Incredibly important finding that I think sometimes is glossed over. The other aspect of the study that we've already talked about this morning is the outcome of patients who have persistently undetectable ctDNA. In a very important finding as well, in part this is maybe obvious, and I don't want to minimize the importance of a finding like this because this technology certainly is critically important to how we're thinking about caring for patients now. But this is also the concept of conditional probability. The longer something doesn't happen, the less likely it's going to happen. And if you plotted a PET scan like this with a survival outcome, you'd probably see something similar. The longer you don't have an event, the less likely you're going to have an event. But that said, important in patients who do opt for ctDNA monitoring. So how do we think about all this in the context of modern? Well, for patients with detectable ctDNA after surgery, here's the curves with adjuvant atezolizumab. In those patients, we got to do better than this. We need escalation in these patients. I think that's clear. Showing that immune checkpoint blockade improves outcomes in this patient population, incredibly important, but we got to do better. In patients with undetectable ctDNA, demonstrating that treatment on molecular recurrence improves outcomes is a completely distinct question than whether or not immediate adjuvant treatment or whether or not treatment in that setting is non-inferior to treating immediately after surgery. IMvigor11 did not address that question. It didn't ask that question, so it can't answer that question. So we think modern is still critical in terms of really making sure that we're not doing a disservice to patients by not giving them treatment immediately after surgery. If that's a curative window for treatment, because remember, when we give adjuvant treatment, we're trying to cure patients, not only prolong disease-free survival or overall survival, which is not the same thing as cure. Last slide. So there's a few moving pieces, of course, in the field in terms of how the adjuvant space might be determined in the future. One of those is that, of course, EV303 and 304 include adjuvant EV plus pembro for all patients, regardless of pathological outcomes at the time of cystectomy. That's how the trials were designed. Volga, on the other hand, which we haven't seen the results for yet, that includes only immune checkpoint blockade in the adjuvant setting, so neoadjuvant EV Durva, but only adjuvant Durva. And then modern is ctDNA guided. It is conceivable, based on how all of these trials read out, that it's the convergence of this data, because remember, the control arm of modern is similar to the experimental arm of Volga. It's conceivable that convergence of all of this data will help to define how we should treat patients after receiving neoadjuvant EV plus IO-containing therapy in the future. So I'm going to stop there. I think we have all this great data, incredible amounts of data establishing clinical validity for ctDNA in recent years. We need trials to establish clinical utility, like IMvigor11, like Modern. We have to make sure that we can enroll those studies before this testing is being done widespread, and treatment decisions are being made based on the results of the test without actually showing that those treatment decisions lead to better patient care. So thank you for your attention. I'm going to stop.
Matt, thanks so much, as always. Very succinct, very insightful, very much to the point. And there's going to be a lot of discussion around what you presented. I think what we're going to do is hold those questions for the roundtable part of things, and we'll move right into Professor Necki's. We can ask Elizabeth in the roundtable as well.
Yes, just addressing the question. Myself and then Betsy have the same question to you. Congratulations, first of all, on your role in leadership.
Sorry, Andrea, your mic's not on.
Outstanding trial. I'm sorry. Congratulations, Matt, for the presentation and your role in this trial and for the trial design. We had a concern, or a question better, to you regarding the experimental arm in Modern. So are you still, let's say, are you still happy with the relatlimab anti-LAG3 arm addition, or the answer is for sure yes, are you happy? But what do you think that the anti-LAG3 may had in the context of newer therapies that are emerging? Thank you, thank you, Betsy, for highlighting the question.
It's a great question, and I think there's a number of targets that are highly attractive in this disease, and whether or not we explored those therapies in the right clinical disease state with the right endpoints is always a major question. So lack of data from across tumor types showing that the addition of LAG3 improves outcomes in patients with solid tumors, I think, is a distinct question from whether or not in patients with detectable ctDNA after surgery there's a role for this therapy. We know that LAG3 is an important therapeutic target in patients with urothelial cancer based on single-cell RNA sequencing data and data in model systems. Whether or not this is the right drug in the right place to test it, ultimately that's why we do trials to figure that out. One more quick point about that. That's also a reason why we designed the study in the way that we did. We're doing a randomized phase 2. We didn't jump into a huge phase 3 with a new therapy in this setting. We're gating the phase 3 based on ctDNA clearance. That endpoint, conceivably, we will be able to read out in the next year to year and a half, and then we'll see if we're on the right track or not.
Thank you.
Andrea, do we have time, or we need to move to the roundtable?
Maybe better to move, and then we'll leave all the rest of the comments to the roundtable. Thank you.
Okay, so now moving to you, Andrea.
Thank you. May I have the pointer? So maybe Naraju, is that there? Okay. So let's now present the results of the poll that, as we did last year, we launched among the IBCG folks. So the methodology is pretty much the same as with previous polls. So we launched a few statements with regards of the liquid biopsies, particularly focused on the bladder cancer among the IBCG folks. Again, here the method for setting the agreement or disagreement are pretty much the same as with previous polls. So 75% is the cutoff for determining the agreement or disagreement. The abstainers have been included in the denominator for the counts. So we started first of all with the first statement regarding the specialty. 87% of the responders were part of the IBCG, 23% from the GSRGT. The primary specialty is urologic surgery. 53% of the responders, 26% medical oncology, and the rest is shown here. So the first statement is this one. So let's make the debate lively. So if you have any question, any comment, please send your question via Zoom or make your question now so that we can discuss live each one of these statement results. So in patients with the MIBC, the following tests provide important complementary information. Therefore, the results of these tests should be incorporated into future updates of CCR, clinical CR definition, per IBCG IGSR consensus. So 93% voted for ctDNA, so consensus on this. 57%, so less than 75% cut off utDNA alone. 63% urinary cytology. 67% CT scan, only 42% MRI, and 63% MRI and VIRATs. Is there any burning comment or question related to this statement results?
I think, Andrea, I think it's important to spend a little bit of time on this because one of the reasons we put this question forward is VIRADS is not prevalent in many parts of the US, including MD Anderson. So we will do a multi-parameter MRI. Our guys are phenomenal, but they don't do VIRADS on purpose, right? And I think that's important to discuss because many parts of the world, they are just as good at predicting invasion without using the VIRAD score. So I think a little bit of discussion and then the cytology question, of course, right? Because many places don't have utDNA. Should we be incorporating utDNA and or cytology? And will that get you up to 93%, right? If you add both of them, MRI with or without VIRADs. I think that's worth discussing because we truly want to make this a statement that can be used everywhere.
Yeah, I agree with you. It's important. Thank you, Ashish. So ctDNA, because we will have further statements that we'll discuss incorporating CT and the utDNA. So please be aware of these results that are pointing to the ctDNA role. Giorgio, what is your comment regarding VIRADs and VIRADs application on the worldwide perspective?
Well, to be honest, I totally agree with I don't remember, Ashish?
It's like the drug without the H, so Ashish.
now we remember. I'm sorry. Yes, I totally agree with you because to be honest, we've been applying VIRADs for a while, and we realized that actually we were like pushing our evaluation into a classification that actually doesn't fit very well the neoadjuvant setting. Because VIRADs are great, perform very, very good in the pre-TURB setting, and if you do pre-TURB MR, you should use VIRADs, no question. But in this setting, I agree with you. If you are good at it, you can do it with your evaluation. There is still, in my opinion, no consensus and no standardization of evaluation of MR in the neoadjuvant setting.
Thank you. Betsy and then Matt. Please, Betsy.
Hi, thanks. Our cameras are disabled, otherwise that would be more interactive and available on video. But thanks for this. Thanks for making Zoom available. I just want to say something. I think this is obvious, but just to point out that ctDNA, urine cytology, and MRI measure different compartments anatomically, right? So ctDNA is the circulation, utDNA is the surface, and MRI tries to get at that bladder wall. So, oh, here we go. Thanks. There I am. Hi. So just keeping in mind, it's probably going to be a composite of those things that give us the best clinical complete response.
Yeah, no, totally agree. This was just to highlight individual tests, and the subsequent questions will have composite of different
Yes.
combinations. So
Right,
thanks,
of
Betsy.
course.
Matt?
And maybe this is addressed on the subsequent slides, and maybe you have governance on this, but maybe I'm also pointing out the obvious, but these things are not opinion-based considerations. We generate data, and then we evaluate and synthesize that data, and then we decide if the level of evidence is sufficient to credential a biomarker for a certain clinical decision. So with all of these things, we should be thinking about what level of evidence is required to incorporate it into a definition, because I fear that if it's just based on opinion, then that doesn't necessarily get us where we want to get.
So Matt, very good point. But one of the things is we also want to have an opinion as to which biomarkers we want to study. Because as you might have noticed, many of the trials that are looking at utDNA haven't even collected cytology, which I think is a glaring omission to not do that, because then we have no data, and we will have data on utDNA, but we're throwing out cytology, right? Same thing with MRI. As you heard, we're looking at VIRADs in trials where VIRADs was not meant to be looked at, and we'll have data that might suggest it's not useful, and then people will automatically assume MRI is not useful. So that's why we broke it down this way. So at least we can then recommend strongly that people should collect all these data points.
Yeah, following the comment of Matt, I perfectly agree. Please don't forget, and George is pretty well aware of this, that VIRADs used in the post-treatment assessment, response assessment, are based on a publication in abdominal radiology on 15 patients. So we still have to be very cautious about interpreting and generalizing the virus message as a way of interpreting response. So next statement, let's move on.
Andrea, just one quick comment. I
Please.
think that sometimes the phrasing of the question is also a question, right? How people interpret it. And in my opinion, some of those things are already incorporated in what we do in practice. For example, I think CT scans, right? Already there. Cystoscopy, urine cytology already there. So this is our framework, right? Our where we're standing right now, current state. The question is, if you add on to that ctDNA, for example, do you improve the performance characteristics of that test? Is that a better, marker to correlate with long-term outcomes? So I think building upon a framework may be another way to look at it.
I was just going to add to the point that from the three talks that we have, we also clearly see that the paradigm is a little bit different depending on the disease state. So to the point that Ashish brought, setting up the benchmark of what we think are the most promising, but there probably needs to be some level of thought, and I would say evolution and gradient type approach that for what applies to kidney cancer clearly is not the same in terms of level of evidence we have for bladder cancer, for example.
Yeah, that's great. We are elevating the controversy. That's good. Yeah. That's good. That's good. Let's move on. And we are only at the first statement. Let's move on. There is clear evidence that utDNA, urinary tumor DNA assays are superior to conventional urine-based methods such as Eurovision FISH for detecting minimal residual disease status of the bladder. I've lost the sharing of the slides. Thank you. Agree 33, disagree 43, abstain 22. So we are far from the agreement here. So urologists, please, Sharok, what do you think? Are you still happy in using, for example, Eurovision in determining or assessing response or so?
No, I think the question, as Petros said earlier, the way you ask the question determines also the answer you're gonna get. And in this question, I think was asked very well. The question is utDNA, the evidence we have on utDNA, ripe enough to say the other ones are not good? It doesn't say if the other ones are good or not. Certainly, as Ashish has said, urinary cytology has a really long track record. It's a really solidly established. Eurovision fish, I think, is something that's gone out of practice. There are other protein-based assays. There are RNA-based assays. But to put it in a nutshell, I think what this tells me is people say, yes, some are, the true believers, early believers, they think, well, that's going to make it a difference without evidence. The other ones say, it's just not good enough for me to replace the other ones because it's not shown to add benefit to the other ones. And I think that reflects the literature.
And do you think that would be the case of making a study comparing the two methods, or simply generating newer data on UTDNA?
I think Ashish's point comes to the point that Petros made earlier. If you assess a biomarker, there's three different components you have to look. It's one, it's its own performance in that population, negative, positive, predictive value, depending on the event rate. Number two, how does it add to what you already know in your clinical setting, right? You know already a lot of factors, and I think cytology is one that I think clinicians, urologists feel very comfortable because it has really, in certain settings, really incredible performance, depending on the cytopathologist, but with the Paris classification, it kind of pushes them to really deliver the answer you want. And then the third thing you have to do, and that's, your ROC curve or whatever, the difference, if you have time-dependent Harris concordance index. But this third one is the clinical decision analysis, and we heard it before. How does it change your practice based on the information in the population that you have, the at-risk population you have? So it needs to go through those three statistical components to add the value in a clinical setting. Because it could be that it adds in an abstract way to something, but it's not beyond what you have clinical information. Or it may improve by 10% your ROC curve for a non-time dependent endpoint, cancer present or not, but it doesn't change in your population your decision-making progress, and that depends on the therapies we have. So
Yeah.
at this phase, I think it needs to have, to answer very fast, sorry, I'm slow. It needs to be tested with cytology at the minimum, as Ashish said.
Yeah, I think you made excellent point, Shahrukh, and I do want to point out one thing. Because we have so many urologists that responded to this survey, you're getting to the truth, right? Because honestly, if you ask a audience of non-urologists, they would say UTDNA, it's great. I also want to point out that even though there are multiple markers currently available in the market and being pushed, the only one that's made it into the guidelines is Eurovision FISH. And it's based on a couple of studies. I was part of them. That's not the only reason I'm saying it, but it was prospectively validated by Yair, Lotan, in a multi-center study for response prediction to immunotherapy, right? So cytology and Eurovision FISH are the only ones prospectively validated and in the guidelines. The rest are all out there. None of them are made into the guidelines as of now. So I think it's important to keep in mind that urologists that use urinary markers all the time are not on the UTDNA bandwagon the way the rest of the world seems to be.
Okay, next statement. In patients with muscle-invasive bladder cancer, MIBC, assessment of baseline ctDNA status prior to neoadjuvant therapy may be useful for therapeutic and clinical decision-making. So ctDNA status baseline at the time of treatment initiation, agree 87%. So it's clear agreement here. Is there anyone having any comment?
My only comment is, Sakura, I want to hear yours, but my thought is, I suppose it's useful in the context of subsequent testing or versus a single time point, because single time point, I don't know how much it will change the management.
Well,
but it's probably a baseline for future testing, I suppose. Is that the goal of the question, Andrea?
Yeah, maybe for patient counseling, or regarding prognosis. And so, for example, when it comes that you have a ctDNA negative test baseline, maybe you may discuss with the patient regarding the need to undergo systemic therapy, or you may, in general, to my vision at least, regardless of the type of treatment that you are proposing, just as a way of implementing a little bit the quality of the counseling that you can provide to the patient with regards to the prognosis,
So Andrea, so that would probably be a generally good statement that you have good prognosis, because in those patients, if we think they don't need neoadjuvant, there's the question, why do they need cystectomy then, right? If they are ctDNA.
And also, Andrea, to your point, the language is therapeutic and clinical decision making. and someone may argue we do not have that confidence with a single time point at the time of diagnosis.
Agree.
We don't know what
We'll
this
have
means.
A special statement on this. Agree. Thank you, Petros. Andrea Polo.
Hi,
Please,
everyone.
welcome, Andrea.
Thank you. So this is a great question, but I think that we don't have the data to say these patients with ctDNA positive disease should not get neoadjuvant therapy. So I think it's a good, like Petros said, it's a good baseline so we can kind of follow it along in case there's a convergence, but we don't have enough data right now to say they should not get neoadjuvant therapy. There was a statement, or I would say a proposal before by a urology colleague of mine to say those patients should go directly to cystectomy. And I think that that's a valid question to ask within a clinical trial, but again, we don't have that data to make a decision as to whether those patients don't get systemic therapy or whether those patients shouldn't get cystectomy right now, if they're ctDNA negative.
Thank you. Matt?
I just wanted to add two quick things. One is that, of course, the question about ctDNA are in the context of the specific assay, right? So biomarkers are designed fit for purpose, and it depends on which assay and what evidence has been generated to support a clinical decision with that specific assay with regards to Signatera in the neoadjuvant setting. So I totally agree with everything that's been said. I just would throw out there, we still underutilize neoadjuvant therapy, and we'll see how that changes with newer regimens, but historically we do. And we have some nice data from a large randomized clinical trial, Niagara, showing that baseline ctDNA is quite prognostic prior to starting neoadjuvant therapy. And so as part of a supporting suite of data to have a discussion with a patient about using a treatment that might improve their outcome, I think, potentially information that if available, we should incorporate.
Thank you.
I just like to add, it's remarkable to see how many patients are actually not getting neoadjuvant chemotherapy out there. So if ctDNA is positive, it may make a compelling factor for patients to choose neoadjuvant chemotherapy.
Yeah,
So
I suspect they're starting today in the US. Unfortunately, only in the US at the moment. The wave of EV Pembro will overcome all these the limitations of neoadjuvant therapy administration. So I think that in principle, EV Pembro will be proposed to all comers, regardless of the ctDNA status, regardless of the pathological stage, and so on. So, but we'll see. So let's move on with the next statement. May I have the slides? Thank you.
May I ask? I think this question comes to the core question: is ctDNA reliably measuring micrometastatic disease that is biologically and clinically active pre-neoadjuvant therapy? We don't have any evidence on that before any active therapy. We know that after bladder removal, after the primary removal, and we know there's a gray area that Petros already talked about it, that because some can be cleared. So I think that is a question that remains for me, because you could have, because what Petros said, your 22 to 9% shows me there is cells that are ctDNA positive, but they're clinically irrelevant potentially, because obviously there is some cells.
Great
so
point.
I think there's a risk of, certainly, at the moment we're thinking, because we have a deadly disease, better go with overtreatment. But the problem with oncology has been always overtreated and automated treatment, and certainly this is a clinical relevant scenario to ask if this ctDNA with a single measure will be clinically relevant.
Yeah, great point. And again, going back to the need to have, rather than only the interpretation of positivity or negativity, the quality of the test. So Andrea, you have to move forward with this, internally with Natera. We have to discuss with post-meeting.
And may I add, the question of, in a muscle invasive bladder cancer, there's multiple issues. For us as oncologic affine doctors, we think about OS and EFS. For the patient, we already discussed it, is life, quality of life, but also is bladder sparing the endpoint of and that will change the whole question how we assess these biomarkers.
Shark, I couldn't agree with you more. It's kind of feels like sometimes we hit the nail with a big sledgehammer, right? Is because it is a dichotomous variable versus a quantitative variable, you may just have a bladder that has significant amount of local regional disease, which you haven't controlled, and you're making a decision to give systemic therapy based on this, which clearly is overtreatment. So I agree. It seems like we don't necessarily have the quantitative data to really be able to sort of drive that decision.
Let's move to the next statement. It's quite interesting to me.
Andrea, I just want to share with you one thing. So as far as sharing the actual raw data is concerned, we are in the process, and I was just sharing with Andrea as well, getting the entire raw data, Altera as well as profiling. And I was just actually sorting this out this morning, which is why I didn't show up for breakfast. It is essentially 100 gigabytes per patient of data that we will have to house at MD Anderson. So right now I'm trying to find money to pay for storage. So that is something that you really have to consider when you're thinking about getting all this data. Where are you going to store it? How are you going to house it? What's the informatics going to be?
Exactly. This has to do with the company or with the biomarker development team in order to select what could be clinically meaningful with regards to the ongoing treatments. And so, yeah, I agree that providing the raw data to the patient, it doesn't make any sense. Okay. So in patients with muscle-invasive bladder cancer, ctDNA testing for MRD assessment can replace conventional cross-sectional imaging for post-operative staging. Agree, 20%. Disagree, 75%, let's say. So borderline disagreement, and abstain, 4%. So it's interesting. This would mean that ctDNA could have a role still in this with regards to imaging. What do you think, Andre?
I didn't vote here, but I disagree also. Even being part of the company, but I think we're not yet prime time to say imaging is not enough. It is less relevant than ctDNA, so we're not at that stage yet.
Again, Andrea, and Matt.
Okay, so I would say not yet for this particular question because we did see that patients that were ctDNA negative actually did have recurrence and which affected survival in the IMvigor011 study. That was one. And then going back to the prior discussion that we were having about the details of ctDNA. Right now we have positive, negative, but very soon we will have more quantitative data as to what the numbers are, what that means prognostically. And for the ambassador study, we are doing ctDNA also, and we'll be doing whole genome as opposed to whole exome. So I think we'll get a lot more data, more sensitivity, and that is all coming as we speak right now. The data is being analyzed.
Yeah, thank you, Andrea. We'll discuss about the technicalities of the test later. Matt.
So let me just fast, if I may, before Matt. So everything we assume on ctDNA is now whole exome ctDNA. So all the questions are related to that, probably, that we are currently making interpretations on, right? I assume that's what the assumption that everybody was answered because there's no other data.
Yeah.
So in times as time passes or an article comes out, you have to say this is based on that assumption.
Yeah.
Sorry.
Matt.
So maybe I'll just push the group on that last point, and I'm not sure where I fall on this either, but we have a large amount of data from a prospective study showing that the likelihood of developing radiographic METs before conversion of a ctDNA test with Signatera is about 4%, right? What number does that have to be to omit scans? Scans are expensive. There's radiation exposure. They lead to false positives. They lead to downstream biopsies for incidental findings. So I think this is a conversation that we should be having about the risks and benefits, because there are a lot of these questions that are being asked that we don't actually have prospective data, but we have a large arm on IMvigor11 addressing that very question.
Yeah, I agree that we reached a 75% disagreement, but there is debate around this. Maurizio, and then we will move forward.
What I want to say has already been said. I mean, we are too early to me, so I agree with what has been said. That's what I want to say. Okay.
So let's move to the next statement. I have my slides. So in patients with MIBC, the assessment of MRD post-neoadjuvant therapy, so clearance of MRD with ctDNA and utDNA, can be useful for therapeutic and clinical decision making. 85% agree, 9% disagree for abstain. So the point here, based on the previous results, is to how to best interpret the utDNA contribution to this agreement. What do you think, Petros?
I think the data we have so far are very robust with ctDNA in terms, again, of the prognostication question. I think we need more data in UriDNA. I think the data we have with UriDNA from Sunrise 4 is very promising.
So is there a way of modifying a little bit the statement, or what
I
do you
would
think?
I will probably break it in two questions: plasma ctDNA and urine DNA. I think we have more data with plasma ctDNA we discussed today, and this can be useful for therapeutic clinical decision making, especially for the prognostication question, but also the adjuvant immunotherapy question for immunotherapy naive patients. But urine DNA may be a separate question.
So do you all agree on removing the utDNA component from this statement and leaving just ctDNA from this statement? Marzia.
Andrea, if I may, I would keep utDNA, because in case of disagreement of positivity of utDNA and ctDNA, you can also understand if the disease if the residual disease is systemic or localized to the bladder.
I think, Andrea, it's okay to leave it as is, because this is not like a standard right now. It's just asking, can be useful. It can be. We don't know yet.
I think there is a promise in the future, but right now, I personally do not use urine DNA, and I don't know what to do with the result. So there is implication of cost, logistical burden to the team following the result for a test that we are not ready to use for prime time. And to your point, it can be helpful in the future, but the question is right now, is it coming only from the primary tumor? Is it potential filtration of ctDNA over the plasma to the urine?
Yeah.
I think there are many unanswered questions.
Well, I'm trying to interpret both the results. So the results related to utDNA alone that were negative, disagreement, and these disagreements. So do you think that utDNA plus ctDNA may have a role, so let's leave as it is, as a way of integrating a little bit, not too much, but a little bit, the ctDNA contribution. Otherwise, we have to move.
Or we can say in future, add.
Maybe adding in the future.
Yeah.
What are
So,
thinking the folks
I have a
online,
comment.
Andrea?
I have a comment. So I would say if you're designing a trial, it should be incorporated in the trial, preferably prospectively. Maybe take if it's urine positive, urine ctDNA positive, then you can do a cystoscope, you can do a bladder evaluation. Maybe you can do local therapy and still, if it's a bladder preservation trial and the hope is to keep the bladder, it seems that the urine ctDNA is really a good surrogate for what's going on in the bladder, and the ctDNA is more of a systemic and also bladder. So I would think incorporate it into a clinical trial, but of course not ready for prime time yet.
Okay, let's move on.
Ask you, I had always questions with this. What is therapeutic and clinical decision making? And I tried to see if there's a difference or not. And I was all the time thinking about scenarios, how there can be a discordance between and or, because I was thinking.
Clinical, for example, in my interpretation at least, as we discussed earlier regarding the counseling of the patient with regards to prognosis and so on, information in general regarding the disease aggressiveness and so on, and therapeutic is an integration, So I think
there's
that
two
it's
big differences between the two. One is counseling, and one is giving a probability, and the other one changing your therapy because you're already at the predictive factor. So it's a big bandwidth in your decision making. So the impact that would happen.
So would you remove one of the two?
Well,
so let's
I
say,
think,
for example, stating only therapeutic and not clinical.
Yeah, I think only therapeutic, because that's what you care is that biomarker going to change what you're going to do rather than how you're going to, I mean, obviously how you talk to the patient will be, but we have to get out of that because we're hoping those biomarkers will guide us to change the way we deliver the therapy rather than, you know, I understand that there always is like this discussion. We have to have equipoise, and we're going to discuss this and that, and we're going to leave it to the clinical decision with the patient. But in reality, the patient wants us to get, based on the data, this is what I would recommend you, and not, here have the data and you decide, and that. Because the decision analysis space was never meant to be done with patients, because patients cannot imagine all the therapeutic effect, adverse events. It's too complex. So I think therapeutic would be better, I think, only. And I was
Do you
thinking
agree
about
on
that.
this? So let's leave the clinical part. Betsy, did you post a comment? Would you like to comment? Welcome, Betsy.
About the utility of scans. It's okay.
I think, Smriti, we have someone here that does this for a living. What's your thoughts on the wording of that statement, therapeutic versus clinical? Like, what's your thought?
Sorry, just to answer the previous question about having those two together, I think I agree with Pedro to actually separate them into two separate questions, because, I mean, yes, I get that it has an advantage of localized versus metastatic disease, but I think if it's being incorporated in any kind of guideline, not guidelines, but any kind of publication, then it's good to have that clearer. And again, I would go with therapeutic rather than clinical, because I think clinical obviously has implications in standard of care. So until it's established as something that can be used in clinic, I would probably avoid, just to err on the side of caution. Yep.
Thank you. Let's move on to the next statement. Huge agreement here. In patients with an IBC, results from an IMvigor 11 trial support assessing baseline ctDNA status after radical cystectomy and should change clinical practice. So, are the results of IMvigor 11 practice changing? Agree, 84%. Disagree, 7%. Do you all agree on this? And Neeraj, do you agree on this?
Yes.
Yes.
Short answer.
Is there anyone who disagrees?
I agree, but I think we should be more specific in the language. I think the data is specific for immunotherapy naive patients. I do not know how to apply the data in patients who get Pembro or Niagara. It's a different population because of different prior therapies and maybe different selection.
11 population, right?
Yeah, I would focus on the population that was studied in Vigor 011.
Yeah, and I was just focusing on the, my answer, yes, was just focusing on this question. Yeah.
Yeah, to that point, Petros, in the Niagara also with durvalumab, we saw that, because the evaluable group was very small, so we can't make that statement, but it did show that it has value, whether they're immunotherapy naive or not, right?
It's a great question, Silpa. I still have uncertainty in my head about the adjuvant therapy phase component, and there is risk of over-treatment, risk of under-treatment, toxicity and cost, but based on the curves that we saw with the post-cystectomy ctDNA data, there was separation of the curves and the hazard ratio were low with durvalumab. So with this uncertainty of over versus under treatment, if someone tolerates it well, I would personally to continue adjuvant durvalumab. So it's a little bit different, I think, compared to IMvigor 011.
I also look at it the 30,000-foot view is we should set the benchmark that it should be looked for individual therapies. So I think you, as you said, agree, but I do think the statement needs to have accompanying that subsequent studies need to be validated in this clinical setting, or else you open it up to indications for agents just based on a specific other agent for which it got therapy. So I do think if we want to keep patient care and evidence-based care, we need to sort of establish that as an additional comment.
Let me add.
And then seeing the ctDNA data from the Keynote 905 would be very helpful.
And the thing, sorry.
No,
the
the
thing
next question, yeah, go ahead. Please. So now, Petros, the problem is the moment you start making the questions very long, the answer will be more disagreement, because somebody is going to disagree with some of the aspect of the question. So this question is great, but there can be other questions down the line related to this question. Would you use it in those patients who did not get exposed to immunotherapy versus who did get immunotherapy before? So,
Sure.
And may I add something? What I didn't like, we agree with the general concept of this. What I didn't like is should change clinical practice because it's all about adding a drug. It's not about removing a drug if you thought you're going to add it. And that is the risk of using ctDNA. It tells you that if it's positive, you need to add something, but it doesn't tell you if it's really negative that you shouldn't add a drug, I think, to a certain degree, if you have 12%. But also the setting of the EV Pembro, where we all are afraid you have a sandwich therapy, and now you're going to use ctDNA, and then you're going to say, can I stop a drug? So it should be more precise about saying, after radical surgery, should be given adjuvant therapy.
Sorry,
if it's
you can
if you
use
didn't receive
could, not should.
I would say, into Sakhar's points, again, this is probably subjective, but change clinical practice in my mind covers both scenarios, to your point, add or not add the drug or withhold it. So I think to your point, Sakhar, it's a great point. I think it covers both scenarios of therapy decision making, give or not give.
but
So
this is
I'm still confused about the practice changing nature of the data, because if we change should with could, that means that in Vigor 11 is not practice changing.
But Andrea, I think because atezolizumab is not currently approved, that may play a role here because it was withdrawn from U.S. market, but they are filing for approval in adjuvant space. So I think if, let's say, it were to get approved, it would be practice changing. Right?
But I think we can discuss that in the text.
Yeah.
Right? The statement as it stands, I personally like it. Secondly, I just want to remind everyone, all these statements were run through the Delphi. There's an online tool that tells you if it's Delphi ready or not, and we did make sure that the wording fits the process. So as far as the English language is concerned, Delphi okayed it. Again, we can disagree on the science, though.
Next statement, in patients with MIBC, ctDNA-guided treatment de-escalation in the adjuvant setting as supported by InVigor results may reduce the overall adoption of perioperative therapy, so neoadjuvant plus adjuvant treatment strategies. Agree 71%, disagree 21%, abstain 7%. So no impact on the overall treatment burden in this patient? Is there any comment?
I think this goes to the previous dialogue. Again, personally, I think the data from InVigor 011 applies to this population.
Yeah.
Similar to Segmentus 7.4, I do not think we have enough data to extrapolate to perioperative settings. It's a different population, different therapy setting, different individual treatment, so I don't feel comfortable extrapolating, personally.
I think this, to me, is I think Matt stated it very clearly in his talk, is this, to me, sets up the benchmark of what should be expected for future trials, as establishing what should be looked at and focused in with related to future trials and future agents, right? That's ultimately what we want to do, optimize the outcomes of our patients, but de-escalate care both from an outcome standpoint and also from a toxicity and cost from a healthcare system
Yeah,
standpoint.
I'm actually surprised that they did not reach consensus because this is an important thing to consider for.
Matt, do you have a comment?
Yeah, I just wanted to clarify maybe once more that the trial didn't test de-escalation. It tested escalation. So patients with ctDNA detectable disease were randomized to treatment versus not. To test de-escalation, you would have to test immediate adjuvant therapy versus delayed adjuvant therapy.
So may I have the slide? Otherwise, it's difficult to see.
I agree. And again, I want to make the
Can
point.
we leave the slides on the? Okay.
This is neoadjuvant and adjuvant. Again, we don't have data for de-escalation for neoadjuvant and adjuvant. Perioperative is different than adjuvant only.
So again, just to clarify, this question was worded this way specifically because it's not a recommendation that's being made. It's a caution that's being put forward that this may actually reduce the adoption, and hence the text will suggest that you shouldn't reduce the adoption of current paradigms based on InVigor, right? So that's why this was worded this way. I think the fact that many people agreed, I think at least the impression I got was people were agreeing that we shouldn't use IMvigor data to withdraw people from Niagara or Keynote.
I interpreted that different way, so I think it's very confusing. But because what you say, Assis, makes sense, but then my understanding was exactly the opposite, that we endorse that strategy.
I'm not saying we should reduce. You're saying it may reduce, and hence.
May reduce. So are you happy in removing the de-escalation? Let's say something like CTDNA guided treatment decision. Let's say. So removing the de-escalation wording?
I think the way it is stated, I actually agree it's the appropriate way, because I guess the point of the question is there a risk that it may be overinterpreted and result in unintended consequences? And that's what the question is asking. And I think the answer is yes. Because it can be interpreted by average clinicians there that, well, now that we have ctDNA negative, let's not do the DERVA or let's not do the NIVO, etc. So I think I see it as I agree.
Betsy?
I just wanted to add, circling back to one of the points Matt made, that while we would need to randomize these patients to know if it's just as good to give adjuvant at the time of positivity versus at baseline, we do have the data for those who are serial negative, and few of those recurred. I guess you could debate whether the 4% during the surveillance time and the 12% after is few or a lot. And we did spare overtreatment of those patients. So it's not just, the only question is not whether de-escalation can be helpful, it's how can we avoid overtreatment? And I do think we have some data from IMvigor11 to suggest that. And that's where I think ctDNA is now coming into our practice on that basis.
So there's a 22% chance if you're ctDNA undetectable on that first test after surgery that you'll develop molecular recurrence. What if treatment of molecular recurrence isn't curative and treatment in the adjuvant setting is curative?
Absolutely.
I don't know that we should be. So I don't think we should be
I
cavalier.
agree. We don't know the answer to that question, but we do know that at the end of the day on IMvigor, there was a large group of people who didn't get systemic therapy who did fine. And those patients, at the point you made in your talk, only are harmed by treatment. So we're looking at both spaces. We're looking to see, do we lose people to a potential benefit they could have had? One question. And in tandem, do we save people from toxic therapy they didn't need? I know you know this and you outlined it beautifully in your talk. So I think we're agreeing on this, yes. But keeping our lens on both groups, I think, is important.
Absolutely.
So let's move to the next statement. We are accumulating a little bit of delay, so I'm sorry, Andrea, we have to move forward. In patients with MIBC, a positive ctDNA test after radical cystectomy following neoadjuvant therapies, Durva, Gemcis, EV-Pembro, should be used to inform therapeutic intensification or change rather than continuing the planned adjuvant treatment per protocol or per schedule, like continuing durvalumab or continuing EV-Pembro, and so. Agree, 66%, disagree, 24%, so there is no consensus on this. Any comment? Okay, so let's move on.
Andrea, is that a clinical trial recommendation? What is the intent of the statement?
Well, I see I interpreted the results pretty much consistent with the notion that we got from the clinical trials, So there is no way of changing the Niagara paradigm of EV-Pembro. So.
I think for now, in terms of the current practice, people who, let's say, get EV-Pembro as per EV303, they have the option to go on the adjuvant therapy component. We don't have data about changing therapy.
Yeah.
If we can put them on a modern trial or a different escalation trial, sure. I think clinical trial, it's reasonable, but outside of the trial, I don't think we have data to escalate or de-escalate based on the current data set. So again, it depends on what the intent of the question is. But if it's clinical trial design, sure. But if it's not clinical trial design, we don't have the data to make a definitive statement.
Thank you. Regulatory reimbursement considerations aside, in patients with MIBC who have undergone radical cystectomy with or without neoadjuvant chemotherapy, performing serial, going back to the point of serial ctDNA assessment is superior to single landmark assessments for therapeutic decision making. Agree, 87%. We will also hear from Andre later, so it's pretty much straightforward here. Regulatory reimbursement consideration aside,
Can I
in
just make a
patients.
quick comment on
Please.
that question?
Please.
You don't have the option to make a clinical decision in the same way at serial time points that you do at baseline. So it was a broadly framed question. And obviously, when we look back at serial data, it's more informative than one time point. But when you're marching through that experience in real time, you only make the decision right now outside of the modern trial or IMvigor11 trial, you make that decision at one time point based on what you have, right? To either delay adjuvant or give it. So it's not the same.
I agree. There are also considerations regarding the affordability of serial testing in the real world. Not in the European side, because we are not allowed to make any single assessment, so not a problem for us. But there are considerations regarding affordability for the healthcare system of serial testing. But we will discuss with Andre later. Slides, please. So again, in patients with MIBC who have undergone radical cystectomy with or without neoadjuvant therapy, performing tumor-informed ctDNA assessment is superior to using predefined gene panels. Here we don't have the consensus. Agree 61, disagree 16, abstain 21. So a lot of people abstained.
Andrea, I surmise that some people maybe didn't understand exactly the intent, because the tumor intent, tumor-informed ctDNA assay is for monitoring, prognostication. It's a Signatera kind of yes or no question. The predefined gene panel is more about what you said before, Andrea, about molecular characterization, molecular profiling. So there are different information that may be provided by those tests. For metastatic disease, we use these targeted gene panels, right? Whatever assay we use. But at least in the context of what we discussed today, the quantitative question is what we have data with, not targeted gene panels.
And also, Andrea, there's so many tumor uninformed ctDNA assays out there which are, being used more and more. So I agree, this question we don't need to.
Jeff, you have some points that you made about this.
I couldn't understand the question because I don't know what a predefined gene panel is. It could be a ctDNA using Illumina or proton, classic comprehensive de novo profiling. It could be PCR based. It's too vague, the question. The comparison could be informed versus uninformed, but predetermined gene panels is so broad, I couldn't find a way to answer.
Can you see what the comments were to this that is showing to the survey? Because there was an option for free text, right, for each question?
Yeah, Shilpa, it's not showing right now, though.
Can I add a comment on that? I think it's also a matter of sensitivity, because the tumor-informed panels are designed, just let me know if I'm wrong, are designed in order to be much more sensitive based on the type of mutation that are included in the panel. So at the end, the tumor-informed panels are much more sensitive than the general predefined gene panels. So they achieve a much more sensitivity in terms of detecting the MRD.
Well, as a matter of fact, as also Betsy pointed out in a comment, we don't have data in the adjuvant setting, at least here we are dealing with adjuvant therapy, with use of targeted therapy in patients with certain mutations or use of certain NGS test, The adjuvant tifigratinib study was negative, just to say, remember. So it's difficult. Maybe I interpret that the lack of a consensus here because of the lack of data with regards to non-Signatera test, let's say. Yeah.
And Andrea, maybe another question for the future will be tumor-informed versus tumor-agnostic MRD assays. And then that's one question. And the second question is molecular profiling / characterization with gene panels that we do in metastatic disease, for example.
Exactly. The predefined panels are essentially searching for therapy targets,
Yeah.
trying to optimize
Yeah.
treatment. They're not there for molecular residual disease detection.
Yeah, Jeff said it so correctly. I was thinking about the same. I must have said abstain here because both have different intent. The predefined gene panel is looking for targeting using drugs. First one is for monitoring.
Next statement. In patients with MIBC, using serial ctDNA testing from MRD assessment is mandatory for identifying the optimal candidates for response-adapted bladder sparing approaches. So agreement is 60%, disagreement 27%, abstain 12%. So I think, what do you think? Mandatory, in fact, is too hard at the moment. Is there any comment?
Andrea, could it be because I know majority of people were urologists, and because the question is on bladder sparing approaches? Is that, I don't know, I'm just thinking like everybody says in meetings that this is the thing to go for, so I'm surprised.
Or let's say things in another way. So is ctDNA testing, ctDNA result mandatory to corroborate the CCR, clinical CR definition to use when sparing the bladder? There is no consensus on this?
Correct. And Shilpa, just to stand up for urologists, this question is clearly assuming that you believe in bladder sparing, which we do. The question was worded this way: is ctDNA mandatory, right? And it was worded that way specifically. Yeah.
You know, I'm just very curious if the word mandatory would have been replaced with encouraged. I think this one was way. Not that we can't do the if game, but I do think we would probably have been a different percentage here.
Yeah. But when saying could, let's say, well, I think the strong statements are better for us in order to orient the consensus. Otherwise, we are in the gray zone again. Grain, maybe grain, a bit lighter grain or a darker grain, but we are still in gray zone. So, you know.
Yes. And again, the challenge here, Andre, is in terms of the decision making for bladder sparing, we need more data, right? In that, because again, ctDNA clearance can happen from systemic therapy or radical cystectomy, or maybe trimodality therapy, as Jason said. So I think we need more data to evaluate the clinical utility for bladder sparing approaches using ctDNA.
Betsy, and then we move. Betsy, Jeff briefly, and then Betsy first, please.
Thanks. The word serial is what snagged me here, because you are looking at a patient after neoadjuvant to decide if you should send them to cystectomy or not, and you have one result. You don't have the serial data in front of you. So for that decision for bladder sparing, unless you're talking about using ctDNA to then later, if it becomes positive, send the patient to cystectomy, which isn't something we've yet explored in the currently designed trials, but could, I would just take out the word serial, and then I think you have a question we can answer a little better.
Jeff.
I wanted to add the concept of ctDNA done using tumor fraction for quantification in deciding total versus partial cystectomy. We didn't consider this at all, but for the urologist, the opportunity to do a partial cystectomy and be bladder sparing but yet surgically curable, of course, is extremely important. And I'm not going to say I know that quantification of certain genes versus others could guide whether it's safe to do a partial versus it's likely that it will be more extensive than thought from TURBT data, but it's something to think for the future.
Thank you. Let's move on. My slides. Thank you. In patients with MIBC, using serial UTDNA test for MRD assessment is mandatory to identify the optimal candidates for response-adapted bladder sparing approach. So same as previously, but with UTDNA, agreement 33%, disagreement 54%. Interesting, we have no consensus on disagreement, you know. So we are still in the gray zone for UTDNA. So Antonio, what do you think?
Insufficient data.
In my opinion, we can't consider it mandatory at the moment because we don't have a lot of data about urinary DNA.
But interesting, we have only 54% disagreement rate. So Sharok, how do you interpret this?
I think these questions are framed so that where we want it to go versus where we really are. And in this question, I would almost, even if we merge it, the abstain people are like, I don't have enough data, and the disagree people will say, I don't have enough data, that's why I don't agree with it. But it still does make 75%, which is surprising, right?
Yes, definitely. Matter of discussion in the paper. In patients with metastatic urothelial cancer, so metastatic disease, receiving frontline enfortumab and pembro, serial ctDNA-based MRD assessment may be useful to guide treatment escalation, like dose interruption or one or both agents, in selected patients. Agreement 71%, disagreement 13%, abstain 15%. So in metastatic setting, we are still not so many data, so insufficient for the majority to make any change. Neeraj.
So I'm surprised why there was no consensus here, because it makes sense. It is already happening in prostate cancer.
But how many data do we have in the metastatic setting?
No, I'm talking about metastatic setting.
Yeah.
It's a maybe. So I personally thought my interpretation of this question was, should we be designing clinical trial to address this question? And I said, I agree with this. A PSA at 6 months or 7 months after starting combination therapy is already used to design 3 or 4 big trials now.
I think the reason it didn't reach, it's this time the high proportion of urologists that said, I don't really know.
Even medical oncologists do not know in that setting. So I agree with you, Sakura, and I agree with Andrea's point.
Data from UNITE trial. I saw a poster at ASCO with EV Pembro outcome based on in front line based on the ctDNA, but it's not. It's a retrospective data.
Yeah, it's retrospective and very heterogeneous. But to Neeraj's point, I think a lot of people, and I know Betsy is already doing a trial for de-escalation based on CAT scans, CT scans. So this question, surprising that it did not reach consensus, because ctDNA with CT scans is more informative.
But we need more data. We need to ask those questions in trials. Yeah.
We didn't embed, we thought long and hard about embedding ctDNA as a decision-making biomarker in that trial, and there just isn't good data in metastatic disease with EVP. So all the data are with less effective treatments like chemo and chemo IO. So if we're really looking to need ctDNA negative to withhold the EV, we just didn't have the data to support it. Of course, we're collecting it, so I hope we have an answer to share that might help with this question.
Andrea.
So when the results are pretty drastic, like it turns from negative to positive or it turns from very positive to negative, that's easy. But when it becomes like a different number, like it goes from 60 to 65 or 80 to 100, I don't know what to do with those results. So I don't think we're there yet. We really need the dynamics of ctDNA in order to know how to manage these patients based on these numbers, and I don't think we're there yet.
Thank you. Great point. Let's move on.
Those are great clinical trial questions.
Yes. Definitely. So in patients with urothelial cancer who have completed the perioperative immune-based treatment and radical cystectomy, initiated the first-line therapy after the evidence of serial ctDNA positivity in the absence of disease at cross-sectional imaging, should be discouraged. Agreement 49%, disagreement 30%, abstain 20%. So here again, there is no consensus. Again, I think for the same reason that we have already discussed, basically.
And I think, as you said, I think we need scans to trigger treatment now for metastatic disease. However, back to the design of IMvigor011, you can potentially inform MRD positivity to start adjuvant treatment. So in that context, it can be used. In the context of IMvigor011, it can be used. So it's how depending on how you define the therapy setting. It depends on the on how you define based on the currently available data.
Thank you. Okay, That's all for the statements. So we will.
Actually, we will skip the coffee break.
Yes, we will skip the coffee break. We'll work strongly on integrating all the comments that we received on Zoom that we have collected during the discussion. So everything will be merged together in the paper, and for sure there will be huge room for further discussion and further adjustment. So let's move on to the next session.
Yes, I think it's I'm actually proud of the fact that we're 1 hour behind. It just shows how much discussion we had. But we're going to skip the coffee break. The guys at home, if you want to go for a coffee break, just turn your camera off, please. And with that, Andre.
Thank you again for the invitation, and it's an honor to be in this consensus for the first time, and hopefully we can draw together some good conclusions for practice recommendations and future publication based on this. I was asked to do my talk regarding the development and validation pathways of Signatera testing. Obviously, there will be an overlap between not just yesterday's talk, but obviously the 2 great presentations that were made today. So obviously there will be an overlap after today great presentations by Petros and Matthew Galski. I will try to highlight the development and the technical part of the assay itself, and summarizing all the data that we've been seeing from yesterday, and see how we can move forward and what can apply right now in clinical practice, and also future developments for future clinical trial designs and future strategies. So again, ctDNA is already not just a promising but a current cancer biomarker, highly specific, blood-based, minimally invasive, used in real time to assess the tumor burden, and it has a multiplicity of clinical applications from neoadjuvant to adjuvant. Obviously, I will focus the bladder cancer setting and what we are discussing now. And the concept of MRD, again, molecular residual disease that cannot be detected through the current ongoing imaging exams we have available. So occult micrometastatic disease. And along all the continuum of care, this has multiple applications. So Signatera, as you know, is a personalized and tumor-informed approach using tissue and blood sample. What makes Signatera unique in its setting? There are tumor-informed and tumor-agnostic testing. Tumor-informed is technically more challenging, and in terms of costs, obviously more challenging, but the information it provides us is in fact unique, and all the data that we have available currently proves that. So the big majority of the data in the MRD setting is based on Signatera. That is without any question. So we should rely on tumor-informed information we get from this. So, and all the data we have until now, and that's a big question for the future and how to apply the current data we have based on the evolution and the new tests that are coming. So we rely on the exome sequencing, all exome sequencing to identify unique signature mutations, and then the proprietary technology here and the art, let's say here, it's building this custom design individualized multiplex PCR assay for each individual patient, targeting the top 16 SNVs, so the clonal mutations found on the tumor. Then, with ultra-deep sequencing on the subsequent blood testing to track the presence of ctDNA. And it's not just a matter of positive and negative. Whoa. Sorry. We know that with the results, it's also quantitative. So we don't have yet the necessary data to inform on the quantitative value in terms of prognostic and treatment decisions, but on the result, we state the MTM, the mean tumoral molecules by millimeter. So We are addressing this question, not yet for bladder cancer, but in other histologies. What is the value and the clinical implications of low positivity? Because a lot of patients are positive, but with a very low MTM, and we don't know how to deal with this type of information yet. So right now, what we have is a positive and negative information. And it's not just about exome, so we can talk about the whole portfolio. All the data that we are discussing is based on exome. In Europe, you should know probably we have a very different setting than in the US, but Signatera is also designed on genome with not just 16 SNVs, but 64 SNVs. Obviously, there's an improved level of detection, but we can discuss this after, of course, how to translate all the information and the data we put together with exome. We need to repeat with genome to make it valuable. We can rely on what we have with exome. So those are very important questions because it's probably going to be too difficult to redesign all the trials based on genome. This will be impossible, okay? But it's important to understand we have this technology. And also the technology for urine tumoral DNA based on the Signatera exome. Also the tissue-free MRD for in cases where the tissue is absent or insufficient. This is still directed for CRC, but we are expanding this also in our portfolio. Again, neoadjuvant monitoring, post-surgical assessment for adjuvant decisions, recurrence monitoring, and IO treatment effectiveness. Of course, in bladder cancer, even for metastatic setting, this is of utmost importance. Again, the foundational data, where we see the prognostic value, not just single time point. We are discussing this. Serial testing is way more prognostic and provides a different level of confidence in decision making. So during the whole neoadjuvant treatment, and also after cystectomy. And by this trial, of course, it's foundational, observational, but ctDNA was in fact a stronger predictive factor than lymph node status or pathologic downstaging. The same with overall survival. And looking at the curves of the negative patients after cystectomy with longitudinal testing, so not a single time point after cystectomy, and this is also a matter of debate. How is this sustainable in clinical practice in a short-term future to perform serial testing? And again, the story we've heard since yesterday, so how a negative trial give the basis to provide the first ctDNA-guided randomized phase 2 trial, which is in Vigor 11. So the retrospective analysis in Vigor 10, we saw the predictive nature of Signatera in the positive patients, only those benefiting from atezolizumab, and reinforcing the design of IMvigor 11, so not a single time point after cystectomy, but 1 year surveillance, so every 6 weeks testing to determine if the patients were in fact negative and would undergo surveillance only, observation, or if they were positive at any time point, either the first time point or subsequent time points for 1 year. So treat on molecular recurrence, almost delay adjuvant. The question Petros was giving us on, is this a pure adjuvant or a treat on molecular recurrence? Those are different concepts, okay? But obviously they found they underline here in the same setting. We need to decide after cystectomy, but this is an important question also for the urologists because, and for the oncologists, of course, sometimes the patients are not fit enough to receive treatment right after a cystectomy. So the fact that we don't have the urgency of deciding based on the first time point is also comforting for both the providers and the patients. And then the positive patients were randomized, as you know, for atezolizumab versus placebo. A lot of patients were already metastatic prompted by the positivity, so they were excluded, of course, from this trial and went to first-line therapies. So also highlights the power and the importance of testing patients in this setting. again, negative patients were generally patients with a less aggressive disease. And you can see this by the pathologic staging. So more T2 tumors, T3 tumors comparing to positive patients, and less nodal disease. And also, 60% of the patients were already positive in the first time point. So this is important in terms of discussion, the possibility of doing the test in a serial fashion. Is this adequate in the real world in terms of reimbursement and costs? So 60% were positive, and 70% turned positive until the 20th week. And here the curves already discussed today, so more than double benefit in disease-free survival with a hazard ratio of 0.64 in the atezolizumab arm for the positive patients presented this year. Also the benefit in the OS, so the curves obviously better for atezolizumab, but we want more, and we will discuss that. Obviously the modern trial also addresses this intensification. So we are not happy, even though there's a benefit, and we can personalize and select better patients here, but obviously those are not the curves the patients want. Also, the subgroup analysis is very balanced on the positive patients. Timing does not interfere, so the DFS benefits are consistent whether the positivity came right on the first time point or subsequent testing. And the discussion on the negative patients, there are recurrences. The overall survival at 2 years, it's 97%. Is this enough? And we are discussing this, and we should continue obviously discussing this. Is this enough without a randomization as modern is enrolling? Is this enough to leave patients and to de-escalate patients on, put them on observation? Does this outweigh the potential benefit we are on removing the toxicity from 1 year of treatment and also the costs of 1 year of treatment? So we don't have modeling here in terms of costs yet, comparing both strategies and comparing the added value of de-escalation here, but I think it's also a very important question to see if this outweighs, and even before the randomization from modern on the negative patients, these few recurrences, they matter, of course. We need to optimize this. How can we do it? But the toxicity from immunotherapy is relevant, and also the costs, of course. So there's a big doubt here. Obviously, we prefer the randomized. Obviously, not everyone is comfortable with this observational non-randomized ctDNA arm. And we would like all of your input on this also, continuing the discussion. And together with IMvigor, we have the checkmate information, smaller retrospective analysis, similar populations, and not only was a predictive prognostic value here, but also a predictive signal on the nivolumab adjuvant on the positive patients. Still, retrospective analysis, 133 patients analyzed, but the signal and the information we get from checkmate, pretty similar. Is this enough? Is this enough as a proof of concept to translate IMvigor randomized information to this setting? And I'm speaking only in adjuvant, not entering the perioperative setting. Then comes Niagara, again, as Petros presented brilliantly. What does this inform us in terms of neoadjuvant assessment? So it's very important to understand the concept of early clearance, and we know that early clearance in patients is a better prognostic sign. We see even at baseline there is prognostic information. ctDNA patients go much better. The experimental arm with durvalumab, both negative and positive patients benefited from the durvalumab treatment together with chemotherapy. But this is a very informative way for us to assess and to conclude regarding ctDNA as a surrogate for response. And the clearance, obviously there's a correlation with prognostic, and the better information we get from this trial in terms of response assessment is the positive patients have a big correlation with non-pathologic complete response. Still, the negative patients, the correlation is not so evident. So also some conclusions to make here. Urinary tumoral DNA, so intravesical treatment with TAR-200 together with immunotherapy, presented by Andrea Necchi on ESMO, Sunrise 4. So very good signal for UTDNA in the association with pathologic complete response. 81.5% of patients who achieved the pathologic complete response were negative, and a ROC curve very significant here, so extremely important and complementary information as we are discussing. It's not just ctDNA. We should see locally, both they most likely they complement themselves, and that's why, in my opinion, we should address UTDNA in all the bladder sparing trials being designed now. In this trial, particularly ctDNA, was prognostic, but was not associated with pathologic complete response as UTDNA. A thing to focus also that we've discussed previously, the utility and the data we have with ctDNA on trimodality treatment therapy. So the information we have, as we were discussing, there is a significant clearance rate, but we know that also is prognostic, and all patients that had detectable ctDNA at time of the, patients that recurred all had positive ctDNA when they recurred. So again, and this is not the most used, of course, standard of care treatment, but more and more with the pathologic complete response and the data we have now, we have to consider this for bladder sparing, this option. And again, the signal is there, and we have data recently presented also in this subset of patients, which was underrepresented. How do we fit all this data, adjuvant mostly, in the perioperative era? It's prognostic, so we cannot advocate. We don't do that. We reinforce the prognostic value of the testing, obviously serial testing, but we should not jump into conclusions on the escalating treatment based on the information we have. Hopefully these questions will be partially or mostly answered by modern trial, but it's not just the modern trial itself, it's also the paradigm of having useful ctDNA information right from the beginning. So this can be used to design clinical trials in the neoadjuvant phase. Should we intensify treatment right after a patient doesn't achieve clearance? So a baseline patient, positive patient, or a negative patient starts on standard of care therapy, let's say EVP, for example, in this setting, but if it doesn't achieve clearance, should we continue to treat with the same regimen, or perhaps it's a signal to escalate and going for subsequent therapy? This should be addressed in clinical trials. By the opposite, low ctDNA patients, should we de-escalate them up front? And mostly, what's the added value of clearance and negative ctDNA on bladder sparing? So is prime time for integration on clinical response criteria? And obviously, the issue that modern will hopefully answer, negative patients being randomized, are they okay with observation, or should we still keep doing, even in negative patients, nivolumab? And the positive patients, is intensification a reality? So there's much information we can have in using ctDNA on the continuum of care of the current and future paradigm of bladder cancer. Also, just to highlight, in non-muscle invasive bladder cancer, we keep focusing on muscle invasive, the majority of data, but it's important to understand also this subset of patients, and we see that in non-muscle invasive patients, in this publication, observational, 23 patients, small cohort of course, but 34%, almost 35% of positivity, baseline positivity on non-muscle invasive. So what information in this case we can collect here? So positive ctDNA testing prompted earlier restaging, okay? So we will not wait for the 3 months for cystoscopy or imaging. We promptly do imaging and cystoscopy, and 39% of these patients got to cystectomy. The future, bladder sparing, trying to integrate the data we have right now into the perioperative setting. Hopefully modern gives more information, including ctDNA on EV-Pembro, even if it's retrospective, but we need to address this new era and this new treatment regimen and incorporating urinary tumor DNA. And this is ongoing already. So it cannot obviously be further analyzed because it's not yet recruiting patients. Archer is, of course, but there's a pipeline ongoing this, and we will not stop just in IMvigor adjuvant. We will try to adapt to the needs currently necessary. I will not lose time. It was already pretty much explained. Very anticipated trial. And to conclude and to set the stage for the discussion, a few key takeaway messages. So proven prognostic and predictive value in MIBC, considering also the consensus and the information from IMvigor, we consider it's ready for prime time in the adjuvant setting in that particular set of population from IMvigor 11, so without previous immunotherapy. How to integrate this breakthrough evidence in the perioperative era, so neoadjuvant response assessment, bladder sparing strategy, adjuvant treatment intensity or de-escalation, so we don't have the answers for this yet. Integration of ctDNA for complete clinical response criteria, and expanding also, not forgetting non-muscle invasive bladder cancer, and also other settings like TMT strategy to address unmet clinical needs and the whole continuum of care of these patients. So Natera and Signatera is compromised on pursuing all these unmet need questions, and the amount of data that was already generated and is being generated is in fact a breakthrough in cancer care currently, and we look forward for the upcoming results. There are readouts, but it will take a while, of course, but it's pretty exciting timing for this, and hopefully we move forward the broader clinical adoption and trying to see with the regulatory authorities what should we do, what are the gaps, what are the possibilities to make this broadly available. Unfortunately, in Europe, is not yet available, but we should look forward to it because it's where most data resides. So the other assays, of course, we can talk about next generation assays, but the majority of data is already there. How can we translate this with better technology? We don't know. Should we replicate all this again? It's very difficult. So how to use this information based on the current exome tumor-informed MRD guided treatment in bladder cancer is the big challenge, and we look forward for your opinion and the discussion on this subject. Thank you.
I think that we could open the door to the final discussion that is actually coagulating all the issues and discussion points that we have already made in previous session. So I will open this last session by leaving the word to Francesco. Francesco, are you there? From EMA, to provide a few comments and insights from your standpoints regarding the practical needs or the strategy implementation, you know, of the notions that we have collected during these presentations, you know. And then we will extend to Rick and to the patient voice also, in particular with regards to the use, implementation in real world, and translation in real world of the data that we are generating in clinical trials to make these data available to as many patients as possible, in particular from our side of the Atlantic. Francesco, please.
Thanks a lot, Andrea, and I hope you can all hear me well.
Yes.
This is the second year that I participate in this discussion, and I'm always astonished as how much I learn here. And I really like that you let the regulators go last, because regulation has to follow the science in this situation and not the other way around. Please see me here as an observer, as a facilitator, and not as somebody who's here to sort of put red tape around what are fantastical opportunities from both drugs and potential biomarkers that seem to have effects and that you can use. Of course, there are lots of open questions, and when listening to you, I have been kept asking myself, how can we help? Well, first I have a premise to make that these are personal views and not from EMA, but especially because the European Medicines Agency has limited competence when it comes to medical devices, diagnostics, and especially in terms of access and pricing of drug and devices. So put this aside, a little bit like you've done in the questions of your survey. I think there are at least two aspects where we can work together. One is, some of you mentioned it, the standard of evidence. What is the standard of evidence that is needed to show a predictive biomarker or a surrogate in this type of situation where there are so many drugs, different biomarkers, and do we really need a meta-analysis for each and every device drug combination? We'll never ever get out of it. So in these type of situations, I think discussing unusual, let me call them corroboration of evidence approaches to biomarker validation, in quotes, I think that's something where we could help. We could have a discussion. We could have some, I don't know, scientific workshop or something like that to discuss this type of things. We are also extremely interested to explore the window of opportunity between, let's say, when innovation is needed and when treatment optimization is needed, like when we explore questions of de-escalation or subgroups, etc. And getting the timing right and supporting that type of research, which becomes extremely challenging to conduct, often not supported by industry. If we can have a role there to support your efforts, I think this is something to explore, and especially the standards of evidence for those trials incorporating pragmatic elements is something we can discuss. So that's one element of collaboration. The second element of collaboration is something we have explored recently in the hematology community, looking at MRD in transplant eligible multiple myeloma patients after frontline treatment. Basically, although yes, there is a discussion to be had on standards of evidence, while that evidence is not there yet, but it might be very promising, we have those regulatory approvals like conditional approval or accelerated approval in the US, which are precisely meant to deal with these situations of uncertain knowledge and opportunity cost of waiting for complete evidence. Now, in those situations, it is informative to know what patients and doctors think about how extreme would the result have to be for them to consider certain clinical decisions to be, or therapeutic options to be suitable. And again, here we have long-standing collaborations with academic organizations that we could leverage and work together on understanding what are the risk attitudes of patients and clinicians in this situation. And while we totally appreciate the tremendous leadership that you have also in the clinical decisions, I think it's always, in the end, important for us as regulators also to make sure that we hear the voice of the patient, that these decisions are translatable to patients to understand their perspective as well. So, and with this, I close. I think there are fantastic opportunities for collaboration. And again, Andrea, I thank you very much for allowing me to be here and hope to explore further collaborations in the future. Thank you.
Thank you, Francesco. Very insightful. Very insightful talk. Very insightful talk. Is there anyone from the U.S. side interested to understand more on what could be the perspective of the European side? Sarmad, are you looking at me? Are you looking at me with? I have no answer to you. Maybe Francesco will have some answer.
Yes, so specifically about the Signatera assay, I think we use it. It's more or less routine, but I hear from you and some of our friends in Germany that that's a difficult thing, and I think these regulatory requirements that need to be met and the funding that needs to come after those are issues that are being obstacles on the way. So yes, all of these issues, we want to collaborate with you, so we need to understand them better.
Yeah, exactly. Andre, when it comes to the need, and then I would love to hear from Rick, from the patient standpoint, when it comes to the need to provide the test, we will not be too much biased to focus on Signatera, because it is a discussion that could be applicable to foundation medicine test, whichever test we can use in real world. But what is to you the necessary next step to move forward with the affordability and availability of the test outside of the US, with particular focus to Jew cancer patients?
We are pretty convinced that the next step will be guideline inclusion. So we are pretty much aware, even though the routine use in US and the coverage, but it's the coverage that makes the routine use. So in Europe, we know the process is different than in US in terms of at least recommendation and reimbursement, mostly reimbursement, but without any guideline recommendation, our opinion is difficult to get reimbursement, at least publicly. And we are trying internally and together with advisors to obtain information if the test should be done locally or not, because it may be one of the necessary recommendations for the test to be easily accessible is with local lab.
So Betsy's on there too, but I will tell you, not that we can disclose NCCN conversations, but I do say, as per NCCN in our conversations, we always set the benchmark as prospective validation of trials, of studies, and very actionable information that could be used by clinicians in clinical practice. And so understanding that, I think we've set the stage that all of these studies have to be sort of set to that stage if they're going to be integrated into clinical trials. And until that happens, although there could be claims and requests, I think oftentimes the panel has a challenging time approving or recommending things within algorithms.
We have people, other people from the companies.
Published peer-reviewed data as well, that presentations, as exciting as they are, don't provide us with what we need to analyze the data for guideline purposes.
Eli and Jeff, for the Cypher bladder or the Cypher prostate and the FMI test, we as European have the same limitation, so the availability of the test, affordability of the test, so unavailability of the test basically. So what is your point following the Signatera one?
Well, we're going through the regulatory approvals, so that's a bit of a procedure. The EU has changed over the last few years. It's a new process called IVDR. So if you started early, you kind of got grandfathered in, they call it. But we've had, I think the process it's been a little bit challenging, but I think it will be fine. It's just you have to adapt to a new framework that didn't exist just a few years ago. And then I think the bigger challenge, just to, a lot of our research obviously is done in Europe. Right, so it makes sense that it should also be clinically available in Europe, but a big challenge is the reimbursement landscape here. You're dealing with many countries, And then also within a country, you're dealing with regional health authorities, like here in Italy. I think there are some efforts by the Commission to change that, to streamline that, but it will take some time. Yeah, I know it's very disappointing because we do a lot of research together, but then you can't really use the product.
Jeff,
Well,
expanding, for example, to prostate cancer. So it's crazy that today in Italy, for Italian guys, we don't have any single opportunity to test the tumor for BRCA alteration, provided that we do have olaparib and the PARP inhibitor use, but it's crazy. So what is your point?
Our strategy at Foundation Medicine, I'm wearing that hat, is different. Instead of bringing the test to Europe, it's to get the test done in Europe, meaning massive collaboration, which of course we started with Gustave Roussy in France to bring liquid biopsy to France, being done at Gustave Roussy, with Foundation providing the bioinformatics interpretation and the generation of the report. Then we moved to England, to UK in Manchester. Discussions have begun in Italy. Not sure where they're going, but they're underway. And the idea is, with the regulations, also sometimes about the sample actually physically leaving the country, not being allowed. And also participations in the national health programs versus also participating with private insurance, is to, instead of sending the sample out and trying to bring the results in, is to leave the sample here, get it tested here with the technology done in US, and support with bioinformatics and make it a partnership rather than a send out.
Yeah, I would love to hear from Rick. What is Rick? Are you connected online? Let me see.
I am here.
Hey Rick, welcome to the group. I would love to hear from you. You are lucky because you are living in the US. At least from this perspective, you know. At least from this, I don't enter into the rest of the situations, you know. But at least from the biomarker standpoint, you are lucky.
Very wise.
Exactly,
very wise.
Exactly. So please.
Yeah. So I have to apologize. I'm in and out of this meeting because I'm caregiving for my mom. But so we got a similar challenge on the patient side that we do on the guidelines side, because you always want a high level of evidence underlying whatever the recommendation is going to be. And the riskier your diagnosis, the more risk you're willing to take with treatment, and the more willing you're going to be the more willing you'll be to accept treatment that may be on this cusp of credibility from a publication point of view or whatever. So I always love hearing these conversations and getting a better understanding. But you know, I continue to kind of beat this drum, which everybody in this room does, that you've got to have goals of care conversations and you need to be transparent. I think it's a little disconcerting on the patient side to think that you might get different advice from going to one person versus another because of the way the data might be available to them and their understanding of that. So this is really an area that continues to need to be discussed. But if we're not having goals of care and doing shared decision making, which is easier said than done, I think we're selling ourselves and our patients short.
Thank you. Francesco, are you aware of any kind of, let's say, programs that are in place, for example, for drugs prior to a certain approval in a certain indication, like expanded access programs for biomarkers? Has there been any example for biomarkers that have been made available to the patients for a certain indication through expanded access programs?
I don't know for sure, Andrea, but it's entirely possible within the diversity of national regulation and access mechanisms and systems. It is totally possible that both for drugs and diagnostic in vitro devices, there are a variety of more or less efficient ways to get the drugs when or devices when they're not approved yet.
Thank you.
Andrea, can I ask a quick question, Francesco? Francesco, hi, Petros Grivas here. Thanks for being with us. The question I have for you is, there's all this dialogue even in the US about representation of the population of, in the United States of US patients in clinical trials and what that proportional percentage should be or may be or doesn't exist in some trials. Is that the prerequisite to reverse it in Europe, to have European patients in a particular study to inform your decision making about approval, not approval, about a drug or a biomarker?
Great question. The short answer is no. Europe has no prerequisite in that sense for drugs, certainly not for devices. The international guideline that rules is the ICH guideline on foreign data, and it says that ideally these global trials should have the ability to explore heterogeneity, but often that's an ideal. I think personally, the way I look at it is that sometimes there is an obsession that all the evidence have to come from within the trial. So the clinical trial has to reflect each and every possible target population. But think what we do for pharmacokinetic studies, for example. They don't come from the phase 3 trial. They come from other studies, and then so we don't have to study each and every subpopulation in the phase 3 trials. So short answer, no.
Thank you.
Phil, and then we will move to the closure.
So, as I'm just reflecting a lot of our conversations, and I sort of, Rick always brings up very valid points, but I ask myself sometimes, with AI and access to information and the use of ChatGPT and other things, right, is patients probably ask themselves, I want to know what my disease status is, and lo and behold, ctDNA comes in. Does part of what comes out of this developing some standards of what clinicians should explain to patients related to this who are ultimately have this information, want a test but don't necessarily know what a test means, right? The worst thing in the world to me is you have a test that's done but you don't know what to do with it. So for both the general clinician oncologist who gets and uses these tests, establishing some standards, and also what should be sort of explained to patients prior to doing that test and how that test is being used.
Okay, thank you, Phil. So, Ashish, Phil, what do you think? Shall we close the doors? If there is no further burning comment or question, I think that it has been another half a day, quite informative half a day. We will work hard, and the guys out there are working hard.
Actually, Andrea, before we close,
yeah,
I do want to say something. I want to publicly, once again, acknowledge you.
No, this is not necessary.
Your leadership. So,
thank you. Thank you.
And now you can close.
Thank you. Thank you so much. Really appreciate. Really appreciate. So we'll work hard on generating the report of the meeting as we did last year. So we will circulate all the material, the slides, and the most importantly, the first draft of the manuscript afterwards. So have a great rest of the weekend, the rest of the holidays. Wishing you a great Thanksgiving to all the US guys, and see you next year. Thank you.
Thank you so much for making this available on Zoom for us. This was great.